Good morning. Welcome to today's hearing of the Yoorrook Justice Commission. This is a continuation of the historic and ongoing social injustices for Victorian First Peoples, hearing block 7. To commence, I would invite Commissioner Hunter to give a welcome to country.
Thank you, Chair. So I'd like to acknowledge that we are on the lands of the Wurundjeri of my ancestors, acknowledge the elders and the ancestors that come before us so we're able to have voice here today. I do think this is today's witnesses will give crucial information about another system that actually doesn't work for us, particularly health, and falling behind. So I would encourage those online, 13 Yarn, if there is distressing information that they have to listen to today. I will acknowledge that Bunjil will watch over us as we conduct Aboriginal business, and this is a safe cultural space to be able to do that. So, Woman Jekka, come with purpose and welcome to my lands.
Thank you, Commissioner Hunter. Council, may we have appearances?
Thank you, Chair. I appear today with Ms Fitzgerald and Ms Weinberg for the witnesses today. I thank Commissioner Hunter for her welcome to country and for the blessing of her ancestors as we do business here today. I pay my respects to elders and ancestors and acknowledge the importance of this work to the primary health and wellbeing of Aboriginal people in this state.
Thank you. My name is Evans. I appear for the State of Victoria with Mr Lachlan Carter for the Department of Health panel today, Euan Wallace, the Secretary to the Department of Health, Ms Jodie Geissler sitting to his right, Deputy Secretary to the Department of Health, Claire Looker, Chief Health Officer in the Department of Health. Thank you, Commissioner Hunter, for your welcome. We acknowledge that today's hearing is held on the lands of the Wurundjeri people of the Kulin Nation. We acknowledge the traditional owners of this land and that sovereignty has never been ceded. We pay respects to Wurundjeri elders past and present and Aboriginal elders of other communities and other First Peoples who are here with us today and watching online. Thank you.
Thank you very much. Thank you.
I might start with you, Professor Wallace. Could you please state your full name?
Yes, Euan Morrison Wallace.
You're the Secretary to the Department of Health, a role you've held since February 2021.
Yes, I've been in a secretary role since November 2020, what was then Department of Health and Human Services, and then Department of Health in February 21.
Thank you. Is the evidence that you will give to the Commission today the truth to the best of your knowledge?
It is.
Ms Geissler, I might come to you next. Could you please state your full name?
Jodie Nicole Geissler.
Geissler, I'm sorry. You're the Deputy Secretary for the Department of Health, a role you've held since March 2021, is that correct? And is the evidence you're about to give to this Commission the truth to the best of your knowledge? Dr Looker, could you please state your full name?
Claire Olivia Ruth Looker.
You're Victoria's Chief Health Officer.
I am.
And have you held that role since July 2023?
I have.
Is the evidence you're about to give to this Commission the truth to the best of your knowledge?
Yes.
The Department of Health has prepared a response to a request for information issued by the Commission, which we may go to at some point. Just for the transcript, the document identification number is DOH.0004.002.008, and there are a number of annexures which will be included in this morning's tender bundle.
Thank you, Council. Welcome.
There may be some additional documents, Chair, that I'll come to in due course.
Thank you.
Professor Wallace, I understand you have some opening remarks you'd like to make.
Yeah, thank you.
Please go ahead.
Thank you. Good morning. And Commissioner Hunter, thank you for your welcome to country. And Commissioners, thank you for the opportunity for me to appear with my colleagues from the Department of Health before you this morning. And I too acknowledge that we meet on the traditional unceded lands of the Wurundjeri Woi-wurrung people and pay my respects to Commissioner Hunter and Wurundjeri elders, past and present, to other elders, especially to Bunurong elders on whose traditional lands I and my family have always lived since coming to Australia, to other other First Nations peoples present here today and viewing online. I also acknowledge that sovereignty was never ceded. Commissioners, I acknowledge your leadership in this landmark process. And if it pleases the Commission, in accordance with the preferences of the Victorian Aboriginal Community Controlled Health Organisation, VATCHO, this morning I will use the term Aboriginal people to respectfully refer to Aboriginal and Torres Strait Islander people. In doing so, I'd like to acknowledge the leadership that VATCHO provides us all in the health sector, particularly its CEO, Auntie Jill Gallagher, and its chair, Mr. Michael Graham, also CEO of Victorian Aboriginal Health Service, VAS. Commissioners, you've already heard evidence from both Auntie Jill and from Mick, and from other health leaders from community and from academia. I and my colleagues have listened to that evidence to date carefully, and we thank them for it. More broadly, I also acknowledge the leadership role that the Aboriginal Health and Wellbeing Partnership Forum plays in determining the healthcare priorities for Aboriginal health and wellbeing in our state. And last, I acknowledge and thank Ms. Nicole McCartney, a proud Yoorrook woman, who is my Chief Aboriginal Health and Wellbeing Advisor. I have learned much from her and her team and continue to do so, and for that I am most grateful. I am the Secretary of the Department of Health, and I've been in this role for just over 3.5 years. I'm a Scottish Australian. I was born in Scotland. My father's people are from the west of Scotland near Glasgow. And my mother was of the Morrison clan, originally from the Isle of Lewis, but since the 1700s from Ross and Cromarty in the Scottish Highlands. I migrated to Australia almost 30 years ago with my wife, Karen, and then very young family. The World Health Organization defines health as a state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. It's a definition that aligns perfectly with the holistic Aboriginal concepts of health and well-being, of social and emotional well-being, as well as physical well-being. It's a definition that, in my view, should inform and shape healthcare provision more than it does today. The enjoyment of the highest possible standard of health is a fundamental human right, without distinction of race, culture, or religion. There can be no wealth without health, whether that's at an individual level, at the level of community, or as a nation. And by wealth, I mean not just economic wealth, although I do mean economic wealth, but more importantly, social and cultural wealth. You've already heard from others about the social determinants of health, the conditions in which people are born, grow, work, live, and age, and how, since colonization, Aboriginal people have been malevolently and persistently disadvantaged in manners that have purposefully prevented them from being able to even remotely enjoy their best possible health. The forced removal of Aboriginal people from their country and their family and their culture, and the forced removal of language from them, actions seeking not just to diminish Aboriginal people, but to erase them, and actions that have fundamentally undermined health and well-being in a transgenerational manner. The traumas experienced by past generations remain visible today through the poorer health outcomes of their descendants. And there are both biological and social explanations for that transgenerational impact. Shamefully, you have already heard that health services, the very services that should be providing care for you, have been complicit in many of those actions in the past and today. Aboriginal people denied access to healthcare, being forced to give birth on hostel verandas, and coloniser settler healthcare that is not fit for purpose for Aboriginal people. Commissioner, as you've referenced in your welcome. To use Auntie Jill's phrase, a cultural arrogance in healthcare provision that has, without thought or care, disrespectfully swept aside traditional ways of health and well-being. You've heard that even today, some Aboriginal people are denied the care they need, that they experience racism in our mainstream health services, and that our services are still not safe places for many. I am sorry, and this must change. Set against those failings of mainstream healthcare, you've also heard about the successes and effectiveness of Aboriginal-led health services. We may get to discuss some of that in more detail later this morning. I'm committed to placing more Aboriginal healthcare in Aboriginal hands, not just because it's the right thing, although it is the right thing, but because it works. So I and my colleagues are here to listen and to learn, but also to provide you as best we can with the information and insights that you need for your deliberations. I've spent my entire career in healthcare, nearly 30 years of that in the place that we now call Victoria. Victoria has one of the best healthcare systems in the world. We have among the best whole of population health outcomes in the world. That those are not equally shared and enjoyed by the state's First Peoples is unacceptable. And for that, I'm both sorry and I'm committed to the necessary change. Thank you.
Ms. Geissler, pardon me, would you like to make some opening remarks as well?
I would, thank you. Thank you, Commissioner Hunter, for your welcome to country. I would like to pay my respects to the traditional owners of the land on which we gather today, the lands of the Wurundjeri people of the Kulin Nation, and acknowledge that sovereignty has never been ceded. I pay respects to elders past and present, to First Nations people in the room, including my colleagues and the staff of the Commission, and to those watching online. I too thank Commissioners for allowing me to participate today. I want to take the opportunity to also acknowledge the evidence provided by many First Nations people about experiences in our hospitals and health services. Evidence that clearly demonstrates that hospitals have not been places of care and healing for many First Nations people. The history of hospitals being part of the forced removal of children, the continued experiences of discrimination and racism. Healthcare that does not acknowledge First Nations ways of knowing, being and doing, and the impact that this has on health outcomes. I also acknowledge the hard work of Aboriginal healthcare workers across the system, and that of ACCOs provide care that is inclusive of social and emotional wellbeing. This evidence and this process of truth-telling is of deep importance to my division and the department to deliver the required change and the hopes expressed and for self-determination.
Dr. Looker, do you have an opening statement you would like to make as well?
Thank you. Thank you again, Commissioner Hunter, for your welcome. I'd also like to acknowledge that we're meeting on the lands of the Wurundjeri people of the Kulin Nation and that this sovereignty of these lands has never been ceded. I pay my respects to their elders, to other elders in the room, and also to other First Peoples in the room who are joining us here or online. I also acknowledge the critical contribution made by Aboriginal colleagues, and Professor Wallace mentioned particularly Nicole McCartney and her team to our work in the department and also across the health sector more broadly. And I thank you for the opportunity to participate today. I recognise it's a great privilege to be part of this truth-telling process, and I'm also committed to the opportunities for change that it brings. Thank you.
Thank you, Commissioners. We acknowledge that Ms. McCartney is in the room as well. Thank you. Can I just start with a few sort of organisational questions? Professor Wallace, you're an obstetrician and gynaecologist by training.
I am.
And you had an extensive period of clinical practice and clinical leadership in that field.
Yes.
You're also an academic, a researcher, particularly in issues around pregnancy and fetal development.
Yes.
You were seconded to the department in 2020 to assist with the management of the pandemic, correct?
Yes.
And prior to that, you're working in your academic research. So you have a special interest in maternal health and the health of the unborn child.
Yes.
How has that special interest informed your approach to your role as Secretary of the Department?
I think thank you. I joined government in 2017. So leaving clinical practice in 2017 when I joined Safer Care Victoria as CEO, and then, as you say, in July 2020 was seconded, sort of self-seconded from Safer Care to the department proper to help with the pandemic response. I mean, my entire clinical career, I think it probably matters not that it was in obstetrics and gynecology, although it's been a privilege that it has been in obstetrics and gynecology, has informed, my entire philosophy around what healthcare is about. And I tried to bring some of that to Safer Care when we established Safer Care in January 2017. One of our mantras, if you like, but it was in our DNA when we set Safer Care up, was patient first and last. It was all about my clinical experience shaping my own views of what healthcare is about. There is no healthcare without care, and that requires having the needs of the patient or the customer or client and her family first and foremost.
Do you have a special interest in women's health, maternal health?
Yes, I do. Yes.
And does that affect the way you approach those issues of women's health within the department?
Well, I'm a secretary. My role is to ensure that the needs of our entire population are best met. Of course, I have an inherent bias because of my professional background in women's health. I think women's health more broadly has not received the attention that it should have done over a very long period of time, not just in Victoria, not just in Australia, but worldwide. And I think globally now we're seeing rightly increased attention to matters of women's health, not just in maternity and pregnancy, but women's health more broadly. The fact that women who present with a heart attack are less likely to receive the care that they should simply because they're a woman and because the symptoms present differently and the outcomes are significantly worse than they are for men. So much of that work in the department is actually led by Ms. Geissler and Professor Zoe Wainer, who's the DepSec of Community and Public Health, in whose division the women's health team are largely based.
You've acknowledged publicly elsewhere that women's health requirements have not and are not adequately met today. Is that still the case?
Yes, I think it is still the case.
Yeah. And what's missing in terms of women's health?
Oh, so much. I think fundamentally, at its core, I think the health systems globally haven't listened to women. Last week, Minister and I were in Adelaide for a health ministers meeting, but last Friday morning was the launch of pelvic pain work that the minister is leading with Professor Zoe Wainer and her team. It's fundamentally about listening to women in ways that the health systems just haven't listened in the past. Women with the average time to diagnosis and management of endometriosis of 7 to 9 years. So women trying to work and live in pain for an average of 7 to 9 years before a diagnosis is made, probably at its core because the health system just hasn't listened to them.
So just to get to the heart of that, women are reporting their pain and healthcare practitioners and others are dismissing the seriousness of that pain and the need to intervene and assist.
I think there's very strong evidence that that's the case across pretty much all Western health systems.
Yeah. And for Aboriginal women, First Peoples of this state, I suggest that would be compounded because those women are also not listened to in terms of their health issues. Would you agree with that?
I would agree with that. We don't in Victoria have explicit evidence of that, but I agree with your proposition that the compounding of being an Aboriginal woman and being a woman is likely to make the voice of that woman heard even less.
Would you agree that the woman even attempting to come to a medical centre would be early rather than late, wouldn't happen?
Yeah, Commissioner, I do agree. Again, we don't have overt, explicit evidence focused on Aboriginal women as opposed to Aboriginal people. But as you know, the evidence that Aboriginal people, Victorians are not coming forward for healthcare as soon as they might, had the healthcare system felt safe and knowingly met their needs. There's very strong evidence for that, and you've heard evidence from others, Auntie Jill, from Mick Graham, from Professor Ray Lovett from ANU. But we don't have evidence specifically about Aboriginal women, but I think your proposition of women per se's voices and healthcare needs have not been heard adequately, and then Aboriginal voices and needs have not been heard adequately, I'd like to compound. I would agree with that.
Okay. Excuse me, Professor, would you think you should have data relating to Aboriginal women?
Yeah, well, the short answer is yes. I mean, and we may get to it later this morning. There can be in healthcare improvement language, there can be you cannot improve what you cannot measure. So if we're not measuring, then we cannot improve it. So the short answer is yes.
Professor, you also have responsibility for our mental health system, correct?
Yes.
And you have also elsewhere described that system as broken.
Yes.
Could I ask you to explain the ways in which, in a summary way, the health system is broken?
And I understand you'll hear from colleague Ms. Katherine Whetton and Minister Stitt later today in a specific mental health hearing. The Royal Commission into Mental Health found that our mental health system was broken. And again, fundamentally, because it hadn't listened to the voices and the needs of those. Like other Western healthcare systems, we went through a phase of closing down institutions, trying to provide acute care outside of institutional walls. That was the right thing to do. But we didn't replace it with anything. And so suddenly we had a whole cohort of our community with mental health needs that were no longer met. And the Royal Commission found that, of course, we needed to build additional acute mental health beds, and government has been doing that over the last 3 years, but also about what the Royal Commission coined as the missing middle, provide necessary mental health and wellbeing supports for people who didn't need to be admitted to hospital, if only they had earlier intervention in the community. And those supports were not available. And again, under Ms. Whetton's leadership, and you'll hear from her later, government and department and sector has been trying to build those supports. But in the same way as we've just discussed for the inadequacies of meeting women's health and well-being needs, the inadequacies in meeting mental health and well-being needs has at its core that we haven't listened.
The closure of institutions that you've referred to was the result of revelations or understandings around neglect, abuse, gross violations of human rights of those people detained sometimes and often involuntarily in those institutions, correct?
Yes.
And what you're pointing to is the failure to establish community services to support those people outside the institutions.
Yes, I mean, and look, it was both right and necessary. And if I may tell a story from when I was a medical student. So a medical student in Scotland, I spent my psychiatric rotation a month in what had been one of those institutions in the borders of Scotland and Dumfriesshire. And there were old residents in that institution, women in their 80s and 90s, who had been placed by authorities in that institution in their 20s because they fell pregnant out of wedlock, and therefore they had to be institutionalized. Those were the sort of measures that health care and legal systems had operated on a century ago. So there has been a necessary change as our understanding of healthcare and mental health care practices have evolved and improved. And there is no question that the triggers to the closure of many of these institutions were because of the appalling care, miscare, mistreatment, and fundamental infringements of human rights that went on in those institutions, but also driven by a maturation and an evolution of mental health care itself. You know, what is available to assist and support those with mental health needs.
So those closures occurred, correct me if I'm wrong, in the 90s, early 2000s?
Oh, no. I look, in the timing of the closures in Victoria, probably before I came, I think globally they began much earlier than that, in the 70s and 80s. And when they finally ended in Victoria, I would have to check, probably in the 90s, it would be the final phase.
My point is that we've had since that time,
Yes.
80s, 90s, to provide the necessary resources and support to the community sector to take up that responsibility of care for these patients, correct?
Yes.
And we're still struggling.
Yes, and that's what the finding of the Royal Commission was.
Mm. So, Ms. Geissler, can I turn to you now? I might bring up the organisational chart for the department. So, you lead the Hospitals and Health Services Division, reporting directly to the Secretary.
Correct.
And I don't know how good your eyesight is looking at the white on pink there, but thank you. You have a number of direct reports sitting beneath you.
I do.
And you report directly to the Secretary.
I do.
Now, your role was formerly, the title was Commissioning and Systems.
Yeah, commissioning and system improvement when I first commenced in 2021, yes.
And are those same functions now rolled into this new title?
Mostly, but some of them have been absorbed in other parts of the department. So, for example, I used to look after community health, and now Professor Zoe Wainer takes responsibility for that. I used to look after digital health, and that's moved into an e-health division.
Okay. You're not a medico?
I'm not a medico.
Or other health practitioner by training?
That's correct.
Okay. As the Deputy Secretary for Hospitals and Health Systems, what broadly are your responsibilities?
Yes, so I'm responsible for the commissioning and performance of all hospitals and health services, including ambulance services and public aged care services. I'm also responsible for workforce policy, statewide programs such as cancer and health share, and major projects, improvement projects around ambulance and emergency care and access, and planned surgery and care.
You were formerly the CEO of the Royal Commission into Victoria's mental health systems.
That's correct.
So you have a deep understanding of the systemic issues reviewed by the Royal Commission.
I do.
And the implementation of those recommendations.
Yes, I'm not responsible for the implementation of the recommendations, as the Secretary has indicated. That sits elsewhere in the department, but I have a deep understanding of the challenges, yes.
Do you agree with the Secretary's comments in relation to the brokenness of the mental health system?
I certainly do.
Is it any part of your responsibilities and those reporting to you to address mental health issues?
Insofar as the responsibilities, the day-to-day responsibilities sit with my colleague, Ms Whetton, but insofar as overall performance structures for the health system, that is my responsibility, with my colleagues from the Mental Health Division feeding into those structures. So if I give an example of that, if I set up a performance meeting with a particular health service, there would be an expectation that colleagues from the mental health division would attend.
Okay, thank you. And you have a variety of roles which involve directly engaging with VATCHOs.
Yes, in different roles
VATCHO
over
members.
time. Yes.
And that includes addressing issues concerning holistic approaches to health.
Yes.
Dr. Looker, you sit within this chart as well. I'm sorry, I can't pick you up just looking at the pink page. It must be my...
It's in very small font. Just I sit in.
On the left-hand column, yes. You're just below Zoe Wainer in that left-hand box.
I am, yes. I think I'm the second column across, yes.
And do you have independent responsibilities set out in the Public Health and Wellbeing Act as well?
I do, yes.
Your clinical training is in epidemiology and public health.
Correct, yes.
Many of us became familiar with the work of the Office of the Chief Health Officer managing infectious disease, deploying public health policy during the COVID pandemic. You have responsibility for public health, population health systems, including evidence gathering, statistical data and evaluations, and the Women's Health and Wellbeing Program.
Correct. The Women's Health and Wellbeing Program sits in the division that I'm part of. I lead that along with other leaders also.
And do you agree with the Secretary's comment in relation to that system being effectively broken and failing?
I do, yes.
So do you have some independent role that reports directly to government during public health emergencies?
I do, yes. So part of my responsibilities are to provide public health and scientific advice to the Minister, Premier, Department, Secretary, of course, and more broadly also to the Victorian community and health sector. And I have statutory functions enshrined in the Public Health and Wellbeing Act.
And just in terms of that responsibility, are you always reporting through the Secretary, or is there an independent function as well?
I typically am reporting through the Secretary, but I do also speak directly with the Minister on matters.
So I may direct the next questions to one or all of you, but please feel free to chime in if you would like to make a contribution. Professor Wallace, you've alluded in your opening statement to the vision of the department, the Victorians are the healthiest in the world, and just to use your language. You refer to the World Health Organisation's definition of health being a state of complete physical, mental and social well-being, not merely the absence of disease or infirmity, which aligns with holistic concepts of health and well-being that are familiar to First Peoples. And you note the enjoyment of the highest possible standard of health is a fundamental human right without distinction of race, culture or religion. We can go to the legislation in a moment, but do you believe the objects of the Health Services Act are up to the task when we compare that with the language of the highest standard of health?
I think the objects under the Health Services Act lay out, just that the purpose of health services and the provision of care, about ready access to healthcare for Victorians, irrespective of what those needs are, where they live and who they are. The objects don't set out prescribed standards or goals. I think those are expressed through the strategic plan of the department, through the performance management frameworks that we use to work with health services and healthcare providers. I think the short answer to your question is the Health Services Act lays out foundational expectations of health service provision for our state rather than aspirational expectations.
Right, we'll come to that in a moment.
Sorry, is the Act, has the Act been updated since 1988?
Yes, it has, Commissioner. Yeah, so it has a number of amendments, updates over time, the most recent of which was last year, I think, around quality and safety.
The Act that I've currently got up, and I'm assuming it's the current one. If I do a quick find, the word Aboriginal does not appear once in this Act, and we're actually overrepresented in all the criteria. So there's nothing in there.
And as you may be aware, on the 1st of July coming, so in a couple of weeks' time, there is another amendment that will become live, both to the Health Services Act and to the Public Health and Wellbeing Act that governs the Chief Health Officer's powers around formal recognition of Aboriginal people in health care provision. But you're correct, until that amendment, there is not an explicit mention of Aboriginal people in the Health Act.
So what will that Act do for the most vulnerable in this country, really? What will it do for Victorian Aboriginal people?
I think the intent of the amendment is to formally recognise Aboriginal people in the Act and ensure, recognise their needs, and ensure the intent is to ensure that Aboriginal health and wellbeing needs are met by health services.
We might find that legislation in a break just so we can bring it up for you, commissioners.
Oh, thank you.
So can I just go back a step and come to the Act in a moment, because obviously we need to have the Act that's coming in to make this a useful discussion. Your priorities as Secretary of the Department include investment in prevention and early intervention. You've made that point, correct?
Yes.
And the delivery of healthcare in community, in primary care centres and medical practices, or at home instead of in hospitals.
Yes. I mean, I think, as you know, the healthcare system in Australia is broadly characterised as a two-payer system. So we have two major funders of healthcare in Australia: the Commonwealth Government and state and territory governments. And states, if we just confine our comments to Victoria, the state government is principally responsible for funding state hospitals, public hospitals and health services. Since they were established in the 1970s under the federal Whetton government, the state has also continued to invest in community health services, whereas the Commonwealth government is principally responsible for primary care, including community care. But you are correct to say that, particularly in recent times, the Victorian government has stepped into funding spaces that may have traditionally been characterised as a Commonwealth space. So in recent times, in the last 2 years, they have established 29 so-called priority primary care centres because, and not uniquely in Victoria, but because of the fundamental failure of the primary healthcare space in this country. Inaccessible primary care because of falling bulk billing rates, etc., but in part as a reflection of a stagnation in Medicare rebates for items for healthcare for a decade. Changes that have now happened under this current federal government, but the investment of our government, state government, in primary care is a reflection that without that primary care, understandably, citizens need to access care, so they come to acute hospitals. The most expensive piece of our health infrastructure, and frankly, a piece of the health infrastructure that doesn't best serve their needs. Their needs are best served by their GP or by priority primary care centre or by community health services, or if they're an Aboriginal Victorian, by one of our ACCOs.
So the investment in primary care centres is both useful for a budgeting or a resource allocation point of view, but also driven by the interests of patients in recovering at home.
It's primarily about exactly that. It's primarily about providing the right care in the right place. And for more than half of people who had been attending our hospital emergency departments, that was not the right place for their care. They waited too long to receive care that they could get much faster, that they are now getting much faster in our PPCCs and our priority primary care centres. But more than that, the government has invested in trying to move care that has been traditionally delivered in hospital out of hospital. Now, those care pathways have existed for a very long time. In the state, we've had a program called Hospital in the Home, or HITH program, for a very long time. Over the last 2 or 3 years, we have expanded that program in something that we call Better at Home. So really investing in our health services, asking them, what care do you provide as an inpatient today that you could provide in someone's home tomorrow? That program has been enormously successful. Over 1 million episodes of care, day care has been provided. So just to sort of elaborate on it, over 1 million nights a Victorian has had her head on her own pillow rather than a pillow of a hospital bed, receiving care that yesterday she would have had in hospital. Today she gets at home. That isn't primary care, but it's moving care out of hospital to be delivered safely at home. And the feedback from patients and their families is overwhelmingly positive. So the rates of that care being good or very good are much higher than similar care given in hospital. Complication rates like infections and falls are lower because, of course, they're at home in their own environment, cared for in part by hospital staff, but also part by those who love them and surround them.
Do you have stats on that of how many Aboriginal Victorians have used that program?
I don't this morning. I will see, Commissioner, if we have stats on that.
It sounds like a great program, but again, would our people feel safe accessing that, having people coming into their home due to all the issues that we know?
And when we set the program up, and mindful that the program is quite young, it's 2 to 3 years old. When we set the program up, it was about necessarily, I think, at the time, it was about providing explicit and additional funding to hospitals to say, you're providing this care today in your beds, can you now provide that care in the patient's bed at home or in the patient's home? We haven't fully evaluated the program. We've done some interim evaluations of the program, which is how I can share the very high rates of satisfaction, but also the very low rates of complications. But one of the things that over this past 12 months in particular, we've been turning our minds to, really triggered by VACHO and ACOs and community health services, could we not be providing that care? So again, understandably, I think we targeted the funding to our hospitals to move the care out. I think it is now time to ask the question, could there be others providing that care? And to go to your point, if the care was being provided at the outset by an ACO or an Aboriginal-led provider, is it more likely that that service would be used? I think the short answer is yes.
Yeah.
Sorry.
No. I was going to ask a Medicare question, but you can.
Just to understand the pathway there, the patient presents with an acute issue, or just presents because they're not presenting to their primary health care or their GP.
There are broadly two pathways, and I don't oversimplify it. There's an acute pathway and a subacute pathway. The acute pathway is essentially that a patient, for whatever reason and through whatever means, presents to hospital. It might be through ED, but it might not be through ED. It might be through an elective admission for something. And so they're an inpatient, and then they get to a point where they no longer require to be an inpatient. They could now be an outpatient, or they still require inpatient-like care, but they can now receive that in the home. And look, it's not unique to Victoria. I think other places in the country, but other places around the world are doing exactly the same. We're really trying to remodel care so that our hospitals are providing care for those who cannot get their care at home. And and expand the complexity and the scope of the care that yesterday was provided in hospital, but tomorrow could be provided in your own home.
And that's provided, my question was around the
The
hospital.
hospital
provides
staff,
an outpatient service.
well, it's not so much an outpatient service, it's still outpatients typically, outpatients are typically you come for an appointment, like you go to your GP, you go to a specialist, and it's a follow-up appointment. This is still a continuum of care. So the patient is still nominally admitted to the hospital. It's just that the hospital is now in their home. And the care is being provided by the hospital staff.
I see.
But to go to Commissioner Hunter's point is, could that care not be provided by somebody else to expand the capability and capacity of the system? And we've been challenged in that, not just by you this morning, Commissioner, but by VACCHO in the past and also in recent past, but also by community health service providers. And the short answer is, of course, yes. We have a skilled and diverse health and wellbeing workforce, and we need to utilise the full scope of that workforce.
I will say, we've heard evidence, and you have already admitted that it's quite culturally unsafe in hospitals or using the hospital system. So just in evaluating that and understanding, and I know from the Commission hearing evidence, but others that particularly our elders would like to be at home in their own environment, particularly at those particular last days of life. So I would encourage, just from my point of view, to look into what that could possibly look like to be held by an HO.
In terms of the levers that you have for ensuring that hospitals are providing services that are culturally safe and adhere to anti-racism programs and policies, how do you ensure that the hospitals are sending people who are appropriate into people's homes? So I've asked that poorly. What are the levers you have as a department over the conduct of hospitals in their day-to-day business?
We commission services. We commission the services provided for hospitals, and we ask hospitals and health services to sign up to a statement of priorities. These are the services that you will provide for your community. Those statement of priorities, or SOPs, are co-signed typically by the board chair and the minister or a senior official in the department. And supporting those SOPs is a performance management framework that's overseen by Ms. Geissler and her division. And if there are deviations from performance standards, then we would have conversations with hospitals and health services. Ms. Geissler's team already have regular meetings with all of our health services to have conversations around performance and challenges and opportunities. But where there is deviation from expected standards, then we might have specific meetings.
Ms. Geissler, can I invite your comment on the efficacy of the department coming in and saying to the health service providers, the hospitals, you're not up to scratch in terms of, sentinel events, in terms of racism, in terms of anything else?
Yeah, so as the Secretary has outlined, we have expectations that we set under the Statement of Priorities, and we have measures against those expectations. We have a performance process where we have guidance through the performance management framework about how we can step through when we have a concern about a performance issue. And sometimes when we're discussing qualitative matters around cultural safety, historically we have found it hard to do that in a systematic, thorough, comprehensive way across the state.
Sorry to interrupt you. What is a standard cultural safety?
Yes, so there's priorities within the Statement of Priorities, and cultural safety has been in there for the last few years. Yep. So we do have processes around looking at the Statement of Priorities, so the qualitative data, qualitative information rather, and quantitative data. I'm happy to go into that further if it pleases the Commission. But I would say that historically we've had challenges, and the minister's statement responds to this, challenges in terms of walking through every step of the performance framework with our health services when it comes to cultural safety.
So if someone breaches these standards consistently in a hospital, what's the outcome? What happens to the hospital?
So when it comes to, so we've got two measures. Probably the easiest way to speak to that is around the quantitative data, which is measured. So we have two measures in the statement of priorities around, we call proxy measures for cultural safety. That goes to did not wait in an emergency department and left against medical advice. Those are the two measures. We have data monthly that comes into the Department of Health Services on those two measures, and we compare Indigenous versus non-Indigenous outcomes. There is an expectation and a target in the statement of priorities that there would be 25% improvement year on year by our health services against those targets. We are changing that next year to be no gap, but needless to say, that is a mechanism to have a conversation around cultural safety. We have had cultural safety conversations with health services where we have seen the trajectory not heading in the right direction regarding those two measures. Have we taken all the steps in the performance framework to remedy those situations? No, we haven't.
So our people aren't attending because they're culturally unsafe, and there's really no true mechanism to hold anybody accountable for being culturally unsafe. And I'm just going to add, there was only a month ago, I was in hospital with my daughter, and it was really culturally unsafe for me. So I've seen it firsthand. We actually didn't end up getting treatment because we left early. So this isn't good enough. Our people are dying because they're not accessing, and there's no accountability for anybody or any hospital that doesn't reach this standard. I don't actually expect an answer. We need to do something, and it's drastic. Like, it's crisis point for our people of not attending hospitals. I've seen people not attend and then find out months, maybe years later, they've got cancer and it's just too late. Things like that are not acceptable for our people. And as you would know, if I call you Euan, our women attending when they're pregnant as well, or not seeking treatment. If you don't seek treatment, the department comes involved. There's all these cascades and flow-on effects for not having cultural safety in a hospital.
Out of the performance targets, how much of them are linked to funding? And I'm not talking about the Aboriginal targets.
Well, the statement of priorities really is, it has a funding component, but it's an overall bucket. It's not broken down against each performance expectation in that.
So if a hospital doesn't deliver on the statement of expectations, what happens to them?
There are a few levers under the Health Services Act.
Yep.
So the most extreme of those would be dismissal of a board or appointment of a delegate. Those are the most extreme. Mostly what we do is we work on remediation plans with health services where we have a deep concern. So we'll chart out a course of action. We have done that a couple of times with health services where we've been concerned about those two proxy measures I mentioned, but they haven't gone through to the full, the quite extreme measures, I think, the minister's powers really under the Act in terms of dismissal of boards.
How much weight do you give cultural safety and racism in these statement of expectations? Probably can you link it to tangible review mechanisms rather than personal opinion? Like, how much weight do we really give it? Because it doesn't feel, the responses I've heard already today, that there's much weight given to it.
I understand the question. In the statement of, the supporting document, the performance framework has a raft of measures, and I think this current financial year there was about 46 measures, I think, roughly against the quality and safety bucket, and two of those were the cultural safety measures. And I'll get you the specific numbers if we have a break, but we have condensed the priorities significantly in this most recent statement of priorities as we head into the next financial year. because a long list of expectations doesn't allow us to distill properly the conversations that we should be having. So we'll still have those proxy measures heading into next year, but they'll be in a much shorter list of expectations.
With respect, so it doesn't answer the question on how much weight they're given. I mean, I'm hearing a lot about, bringing them all together, but I'm not getting clarity around how much weight cultural safety is given and racism. We just heard the Commissioner articulate a lived experience here, and we've heard hundreds of stories, including my own, where my brother was turned away from a hospital, and not long after that, because of his experience around cultural safety and racism, he died, 42. So this is deeply personal to all of us and our people listening in as well. So we're trying to really understand and get clarity from the questions that we're asking here. And I think that's, I'm just not feeling or hearing rather than feeling, what does accountability look like? If you are the Deputy Secretary tasked with performance and overall delivery on those performance mechanisms, then I'm trying to understand how that role can, further drive that, I suppose.
Thank you for the question. I'll be happy to respond. I think fundamental to moving forward, beyond the technical answer I've given you, is the work that VATCHO is currently doing. It's a huge piece of work around how we accredit our hospitals against cultural safety, how we set standards differently. Once that work is complete, it will be my responsibility, along with shared across the department, about how that is implemented. I think that is a very solid pathway forward. It is an enormous piece of work for VATCHO. But once we have that, I think the pathway forward is a lot more solid, the conversations and the expectations.
And is there funding, I don't need to know the figures, but is there funding to VATCHO to undertake that work and that analysis?
I understand there was, but I'll have to. Yeah,
I think so. I'd like to get a report back on that. Thank you. Thanks, guys.
How far is that work along?
I think there's draft documents, and I think there's conversations occurring between my colleagues in the department and VATCHO on those documents.
But just coming back to the accountability architecture, Safer Care Victoria is the agency responsible for healthcare quality and safety, correct?
Yes.
They assist health services to learn and prevent patient harm, correct?
Yes.
And there's a system of reviewing of sentinel events, which are defined. Hospitals and others have to report those sentinel events to Safer Care Victoria. And then there should be an accountability piece where families or next of kin, in the case of a patient passing, are informed about the outcome of that review, correct?
Yes.
If a family was not informed about the outcome, or there was an unsatisfactory response from their point of view, where do they go next?
If I may, I might just step back for a moment to explain the sentinel event reporting in the programme.
Yes.
So it is a programme. So a sentinel event are defined nationally by the Australian Commission Health Care Quality and Safety. Victoria has its own additional category. So in addition to the national categories, Victoria has an additional category as a catch-all. They're meant to represent the most serious adverse events in healthcare delivery in our state. About 80%, in about 80% of cases, the patient doesn't survive whatever the event was. Just to give you a sense of how serious these events are.
And the other 20% are serious injury or harm.
Well, serious harm, yeah. When Safer Care was established in 2017, rightly, the sentinel event programme transferred from the department proper into Safer Care. And since 2017, Safer Care has been progressively refreshing and modernising and improving the sentinel event programme. Two of the key components of that programme, of those improvements, are assessing. So the reviews, the investigation or the reviews of what led to the event are led by the hospital or the health service where the event happened. So two of the most important initiatives that Safer Care has brought to the central event programme is that those reviews now have rigorous and robust quality standards against them. So when the review is received by Safer Care, it assesses the review for its rigour and its quality, and will then feed back and work with the health service where the review doesn't look of sufficient quality. And sometimes we'll step in and actually do the review itself. And the other significant improvement, and there have been many that Safer Care has done, but the other significant improvement is they have brought the patient and or her family to the table, with a requirement that is progressively getting traction, where the patient, or if patient hasn't survived, the family are invited to be part of the review. Now, that's really important because there are insights provided by the patient or her family that are not provided by another party. And it goes to the evidence that the Commission has heard before about the experiences of the patient that has then driven, their responses to the care that's being provided. And in addition, whether the family or the patient choose to be involved in the review itself is provided to the family.
So who is the patient or their family advocate in this circumstance?
Well, Safer Care is there to ensure that the offers are made for the patients to be involved. If there is dissatisfaction with either the process or the outcome, or both, all health services have a patient consumer liaison office or a complaints office. That would be the first port of call for a patient to say, look, you know what, I am not satisfied with my care or the outcome of this review or whatever it was. Ultimately, of course, the Health Complaints Commission, or if it's a mental health issue, the Mental Health and Wellbeing Commissioner, would be an independent resource for patients and or family. And Safer Care itself also takes complaints and tries to advocate on behalf of the patient or the family.
Professor Wallace, I'm sure you're aware that when these matters, in the case of a patient dying, go to the coroner's court for review, the department has not always been forthcoming in terms of the failure of systems. They don't readily admit the failure of systems. Now, that's not universal, I accept that, but there are many instances where the department is defensive and the hospital staff are defensive of their staff. It might be a natural response, but it's not adequate, is it? It's not acceptable.
Well, it isn't. I have to say that is not my experience of the current department.
But you acknowledge that has been the position in the past?
It is possible, yes.
Yeah. And I take it you would direct your staff, you yourself or your deputy secretaries would direct staff to offer all assistance to families and the coroners in those instances.
Yes, yeah, and indeed, government introduced new legislation around duty of candour to support that explicit point that it is important that we are transparent and honest with patients and families, and always, but particularly when things go wrong.
And does that duty of candour, sorry, Commissioner, does that extend to ambulance and policing services as well, where there's an interaction with the health system?
It doesn't extend to police.
Can I just ask, and you would know the system better than I would, my understanding is when there is a death, there's also an internal process that's done with hospitals, but that's never released to the public or to the patient's family?
The intent, Commissioner, well, of two things. First, the duty of candour legislation I've just referred to is that information would be provided. The expectation is that health services, hospitals and health services share information openly and transparently with patients and families. And secondly, that one of those improvements to that central event programme, where the very formal investigation. It's called a root cause analysis, that RCA process, that the findings of that are shared. Not just they're shared, but the patient and or the family are given the opportunity to be involved in the RCA, to hear their voice, and then the outcomes are shared with the family when the investigation is complete. Now, I acknowledge that that we're starting from a very low base. That has not been widespread practice. I mean, it has been practice in some places, but it has not been widespread practice, which is why in part, the duty of candour legislation was brought forward by the department and Safer Care.
Also, with complaints, do you have numbers around complaints for Aboriginal people?
Yes, we do.
Okay, if we could get hold of them, that would be great. I just think every system we have, our people are not encouraged in a state system or feel confident that they can complain or put a complaint in, or that it'll even be answered or responded to.
Is there sharing of de-identified data by the Health Services Commissioner and Mental Health Complaints Commissioner with the department?
Yeah, both mental health. Well, there's formal sharing. Both the commissions and commissioners they publish annual reports on complaints. And actually, while I was at Safer Care, we did some work with the Health Complaints Commission around trying to unify, try to share the complaints thematic descriptions so that we can track trends in complaints using same sort of analytical processes. So when the commission sees an increase in one particular cause of complaints, we can see if it's reflected in our own systems. So both commissions publish annual reports that provide de-identified summary data, and Safer Care and the complaints commissions under other agencies in our healthcare ecosystem, so like APRA, like VMIA, the Public Hospital Insurer, etc., share information in de-identified manners so that they get more timely awareness if you think there are issues going on in a particular service or across the system.
So there's an ability to analyse that data for themes emerging. For example, if there's a persistent complaint or a number of complaints over time of racism in delivery of health services, you would be able to pick that up.
That is the intent. And actually, when I was at Safer Care, we had a PhD student. He was a medical student, PhD student at the time, a clinician called Ben Nowotny, who's now a trainee in obstetrics and gynecology through Monash. He did a beautiful piece of work trying to develop predictors of system failures, and actually reran data collected out of a health service failure in the state. And one of the potential predictors of future failure was that Ben found in his paper, in his study that he published, was a rise in complaints that predated the public awareness or the system awareness of failure by a number of years. So the intent of information sharing is to do exactly as you've suggested, is to get forewarning of something looks amiss here, not just to give early detection of a failure, but actually to prevent the failure in the first place.
So is that happening now?
Yes.
Yeah.
Could I just say that most Aboriginal people wouldn't complain to a government system. So whatever there is probably an under-reporting. Do you have a mechanism which goes through for First Peoples in this state to make a complaint that is safe for them to do so?
No, we don't. And I agree with you that why would I complain when I'm not listened to or I'm dismissed? Or it's something actually that Nicole McCartney and I have been discussing over the last 12 months or more. What would a dedicated Aboriginal complaint process look like for our state's health system? and how could we enact that? So we've certainly doing the thinking about it, Commissioner. We don't have it. Have we acted yet? Have we started building something? We haven't, but there are ready-made facilities that we could adopt and dedicate to an Aboriginal complaints process that could be fit for purpose for the state.
I would suggest that's probably a really high maybe recommendation that we will make, because if people have an opportunity to complain and they're going into the system, they're more likely to use a system where they feel safe enough to make a complaint. And it actually makes it easier for yourself because the place becomes more culturally safe in the first place. And once you understand what those complaints actually are and where they're pointed, it makes it safer for everybody in the system.
I think just from my point of view, I think you can just crack on and get it done now. You don't have to wait for the recommendations of Yoorrook, but crack on. You're already doing some thinking. Let's turn it into the tangible changes that are required. I mean, that's not to take away that recommendations may be made, but you don't have to wait.
Ms. Geissler, can I ask you about the levers that you mentioned before to Commissioner Lovett? These include dismissal of boards, appointment of administrators or delegates, you said.
Yes.
You also mentioned ministerial directions. The Secretary can also issue directions to health services, correct?
That's correct.
At the extreme end, there's a possibility of censure or appointment of a delegate to a board.
That's correct.
Yeah, and I think you said you've used that twice.
Oh, look, those measures are very, very rarely used. They haven't been used in my time for cultural safety purposes. Delegates are appointed to boards for a variety of different reasons and have been over many years. But administrators and dismissal of boards is a very, very rare event.
Given how rarely they're used, and given that you're not the employer or operator of these health services, the state is not the operator, are there effective means for dealing with the issues with these hospitals and other boards?
Look, I think that's a very important question. There are ways, and if I think about particular issues we've had with health services, there are ways we can remediate a situation. So we can send in independent teams to help a health service remediate a particular performance issue they have. And I think this is definitely part of, it is actually one of the most powerful tools we have because it's a process of improvement in a health setting. I think as part of the accreditation standards work that VATCHO's doing, there will be a process inherent in or necessary out of that about how a health service will move through accreditation. And if it fails an accreditation process, how that will be remediated. That work, as I said, is still ongoing. So the nuts and bolts of how that remediation would work are yet to be resolved. But I think there's an opportunity there.
If I may add, and it goes to Commissioner Lovett's question before about the weight that is placed on these measures. So since I think 2019-20, cultural safety has been in the statement of priorities, but the work that we have asked VATCHO to do around the cultural safety standards is to elevate that. So essentially to get a list of prescribed standards on which hospital accreditation is based. That elevates the importance, if you like, of cultural safety as a necessary component of healthcare delivery.
And as he also asked, you don't need to wait for that. You could initiate that work now.
No, and we're not waiting. So VATCHO is delivering, as Geissler said, and as Commissioners has been aware. VATCHO is already working on those cultural standards for us.
I might turn to the current legislation, the Health Services Act. If we could bring that up on the screen, please, Section 9. So while that's coming up,
Actually, before I turn to that, I might ask about the COVID response, just to bring you into the conversation, Dr. Looker. The state emerged from the pandemic with a significant backlog of deferred care, correct?
Correct, yes.
And clinics were closed, surgeries were ceased for a period of time, vital services continued, but under extreme pressure, both in terms of delivery of healthcare and upon the healthcare workforce, correct?
Yes, indeed.
And the burden of that deferred care, including deferred surgical interventions, continues to this day, correct?
That's true, yes.
And I guess you would say we're not out of the woods yet in terms of the pandemic, are we?
No, we're not, no.
So that burden of deferred care and burden on the health workforce, who are presumably all exhausted from the response to the pandemic, continues to this day, and there's a vital need to invest heavily in the healthcare workforce. Do you agree?
I would, yes. Yeah.
Did the pandemic response draw resources away from other aspects of the department's work?
Definitely within the department, but I think also more broadly across the health sector, yes.
And what were the areas that suffered?
So I think there was a pivoting within the department. There was a pivoting of staff resource and attention to according to what risk lay in front of us, which at that stage was, assessed most greatly as being the pandemic. That meant we had reduced staffing in my area, on our broader health protection functions, which is responding to other infectious diseases, responding to environmental health hazards. Also reduced attention to ongoing work in health promotion space, health prevention space, the work that we do driving that both from the department but also across the sector.
So COVID is the new normal. We're now in a workspace where, in a reality where COVID is with us, and those deferred care instances of delivery of services, deferred surgical intervention, all of those things, we're still going to be playing catch up for a long time. Agreed?
I think that's fair. I would reflect, I think, that obviously our health systems have evolved significantly and in how they respond to COVID. So whilst we do still have persistent high levels of transmission across the community, and we're experiencing that particularly in the last couple of months, I think there's less focused resource required on COVID. I think it is better absorbed alongside other business as usual.
As well as you might want to jump in here too, because I was going to ask you about the measures of the department where the department did not perform well, as set out in your annual reports.
Yeah, so in terms of catch up, there are two components to that. One is to ensure that there's been additional resources, healthcare resources available to provide catch up care, and government provided specific funding, for example, for planned surgery recovery. And in this current financial year, the state will have delivered, the state's hospitals and health services will have delivered more surgery than it ever has done in its history, around 40 or 50,000 more procedures collectively than it's ever done in the state's history. And it's seen the planned surgery waiting list fall from nearly 90,000 to 50,000 over 2 years, an extraordinary effort by hospitals and health services. So that's about healthcare provision. And that'll be appropriately slowly wound back as catch-up has been delivered. But the other bit is that, and Cancer Council have commented on this independently, the other bit is that appropriately and necessarily, people didn't come forward for care during the pandemic for lots of reasons. That tail of people still not coming forward, so-called self-deferred care, but these are not conscious decisions, if you understand. That will be a long tail, and I think the Cancer Council have commented that there are some 3,000 or 4,000 cancer diagnoses that we don't know about yet, that in normal times would have been evident. So there's that catch-up care, but it goes to previous points, Commissioner Hunter, whether it's an Aboriginal person or non-Indigenous person, they need to feel safe to come forward to access care. So there are two bits to the catch up, but you're quite right. Your phrasing of COVID is now the new normal. We have some 300 people in hospital today in Victoria with COVID. And we knew that back in 2021 when it was clear the pandemic was going to be an enduring phenomenon for us and for the world. We started planning back then around how do we create. I thought back then we would need 500 additional beds. I remember saying to Ms. Geissler Division, build me 500 new beds virtually. And we've referenced the Better at Home programme before. The Better at Home programme operating today is currently the equivalent to the size of a hospital, equivalent to a hospital the size of the Royal Melbourne Hospital. So effectively, by moving care out of hospital, we've created new beds without actually having to build new beds, if that makes sense. Because we're anticipating that COVID will be an enduring feature of our healthcare system, and we need to build extra capacity for it.
It sounds too good to be true, I have to say, because it depends in large part, as Commissioner Hunter was saying, on people being willing to have healthcare workers in their home delivering services to them. There has to be that level of trust in the services provided, correct?
Yes.
And while it may have a significant cost relief impact, unless those monies are being invested into VATCHOs and the Aboriginal controlled health services, then there'll be potential for another inequality there.
Yeah, it's less about, so what has driven programs like Better at Home was not about cost relief so much. It was about right care, right place. So what care could we deliver at home where people want to be? None of us want to be in hospital, where they want to be. And the quality of the care as experienced and reported by the user, by the patient and the family, looks higher than it is for like care in hospital. So it wasn't about cost savings. It was about increasing capacity and capability of the system, delivering the right care in the right place. But you're absolutely right. If that care, whether it's in hospital or at home, is not seen as safe, then patients aren't going to use it.
Just looping back to the COVID response, Dr. Luca, the department worked cooperatively and very successfully with VATCHOs during the pandemic, correct?
Correct, yes.
And in fact, there have been plaudits internationally for the work that occurred in First Peoples communities in terms of their response to COVID, correct?
Definitely.
So
yes.
what was the winning formula there?
Look, I think from my perspective, I think there were many reasons for that success, really driven by First People community of Victoria. I'd probably highlight 5 things, limit myself to that. I think firstly, and again, this is my reflection, was the pre-existing strength and agility and capability that existed in the community-controlled organisations. I think to recognise that there was a novel and very different threat to community and the risk that posed, particularly for First Peoples in Victoria. So I think there was that initial recognition from community. Secondly, I think First Peoples' very implicit understanding of the holistic approach to health meant that the community-controlled sector and community more broadly was much quicker to realise the need for wraparound supports for not only people who had COVID, but their families and the community more broadly. I don't think we were as quick to recognise that more broadly across the Victorian population. And in fact, I think we learnt a lot from what we saw happening and being driven by community-controlled organisations. I think there was a strong mechanism for coordination between and collaboration between government and Aboriginal health sector. There was the establishment of the COVID-19 Joint Community Task Force quite early in the pandemic in March 2020. That became a key forum to share reflections about the pace that or the nature of the pandemic as it unfolded, to draw attention to where there was a need for priority actions and to advocate to get further resource directed at those. I think fourthly, decision making and resource was in the hands of community much more than it is for many of our other programs. And I think in my mind, that is a much more self-determined process than is always used, and I think was key to success. And then I think finally, a key element of the pandemic response was around communications, community engagement, making sure that all the Victorian community understood the health messaging, the changing nature of testing, vaccination. And we saw that particularly well delivered to First Peoples communities. So the communications there was an opportunity for that to be designed and led and implemented by community-controlled organisations and directly informed by their experiences, and what they were hearing were concerns on the ground. And I think we saw the fruits of that in much lower rate, or fruits of all of those things, but in much lower rates of transmission, particularly in 2020, pre-vaccine being available, but then also in the rate of vaccine uptake across First Peoples in Victoria, which was higher than we saw elsewhere in the country, and quite standout really.
Would you agree that majority of what happened there was true self-determination for Aboriginal people?
Yes, I would. Yeah.
And did that work?
It did. Yeah.
And what was funding like for First Peoples during that time?
So there were different funding mechanisms. There was targeted response and recovery money related to COVID and COVID funds for specific pieces of work. There was also, as Professor Wallace has referenced, the usual funding mechanisms as well that are delivered both from the Commonwealth and the state.
And what was the, what was this strain put on in reporting back? Because we know with funding, without going into all the other funding, and we'll probably get into that later, but what was it like around COVID having to report all this? I will just say that we've heard from several ACCHOs across the state that they felt like they had this bucket of money, here you go, and they were able to save their people, and they had these great outcomes. But what I don't feel like we've learned from that experience.
I think we have learned. Have we learned sufficiently? Probably not, but your characterization is correct. We were at war, weren't we? As a nation, like other nations, we were at war with the virus, and we recognised that to fight this war effectively, we had to give the weapons to the hands of the people who needed it most, and let them manage it. And in the context of our Aboriginal communities, you're right. They were given dedicated funding, as Dr. Lucas said, without the myriad of reporting lines that you have heard from Auntie Jill and Mick and others that are a burden on delivery of getting in the way of health and wellbeing care. And the other thing was that it was framed positively. There wasn't this negative Indigenous framing. It was the vaccine program was stronger together. I was annoyed when the vaccine program for our Aboriginal people created this community unity immunity thing, because it was a brilliant banner for community. We should have been applying it to the whole of the state. And the Bunjil assets, the artistic assets, that particularly for our children, first and foremost our Aboriginal children, but actually non-Indigenous children loved coming to our vaccination centres where we had the Bunjil assets, our artwork. You're right. But I think we have learned. Have we learned sufficiently? That's for others to judge, I think, and for the Commission to judge. We have learned. I think some of the most recent investments over the last couple of budgets around, so two budgets ago, around our urgent care pathways, the funding for prevention, early intervention, for health checks, to ACCO specifically, for them to shape exactly what the interventions are. We've not determined exactly what you'll do with multi-year funding, without the myriad of reporting line. I think we have learned, but have we learned sufficiently? I think that's for others to judge. Probably not yet, but we have learned.
And look, I guess it's a frustration of this commission because we have department after department coming and speaking with us. Health, education, housing, justice, all of them. All of them say they've learned. All of them say they know what to do. All of them have frameworks and strategies in place, none of which are being monitored or delivering and haven't over 20 years. So the frustration is hearing again and again that the evidence is there, the evidence for how to improve health, education, housing, justice is all there, yet it is not being done. We're always being told that we're at the start of doing something, but doing something hasn't happened yet. So having said you've learned, I'm really keen to hear what are the concrete steps, and you know, we've also been told, we've got more pilots than Qantas. We have pilot after pilot after pilot, and I think we had now more frameworks than Bunnings. Where are we going to get something where the rubber actually hits the road and self-determination, as is proven to be effective, is actually delivered?
Well, I think from my own department, and we have heard, I think the partnership forum for us has been fundamental to how we plan and invest in Aboriginal health. Again, I referenced the urgent care pathway investment from the budget one ago. That was a self-determined investment. So through the partnership forum, very strong voices from ACCOs around this is what you need to be investing in, and we have done that, and we've done it in a manner, and we may get to it in further conversations around funding, but we've done it in a manner that is not about single year budgets, funding lots of widgets. It's a multi-year. We've begun in partnership with VACCO through the partnership forum, led by Nicole McCartney, Miss McCartney and her team and the department more broadly. We have begun our 4-phase program around changing how we fund Aboriginal health and wellbeing, not just uniquely through VACCO, but to our ACCOs. Multi-year funding, outcomes-based rather than widgets, trying to remove the burden of reporting that we hear very strongly from the ACCOs that is getting in the way of healthcare or health and wellbeing care delivery. So we have moved to multi-year funding, and the next phase is progressively to remove the reporting burden. So I think we have heard and we are acting. It may not be fast enough for some, and I acknowledge that.
Self-determination you're talking about, how have you involved the ACCOs in the development of the budget bid? So you're talking about the outcome of the budget bid process, but did you involve the ACCOs in the development and the design of the budget bid before it went to Cabinet? Obviously, MOB don't have a say in the Cabinet process, neither do you, but I'm trying to understand if we're talking about self-determination, did you involve them in it? Just yes or no?
Yes.
Okay. All right. And what you're talking about resources that you've transferred over, but what power, what systematic power have you transferred over to ACCOs in self-determination?
In the context of investment, there are no budget bids going in from my department on Aboriginal health and wellbeing matters that have not come through the partnership forum, that have not been identified by the partnership forum as the priorities for community. And one of the 4 working groups that we have for the partnership forum is on funding. Now, have we got it singing perfectly? Probably not. And you know that budget bids, ultimately the bid itself, the business case for the bid are cabinet documents.
Yep.
But in terms of what the priorities are and building those priorities, those are done through the partnership forum by that working group, and they are determined by community.
Yeah. I guess thanks for that, and I understand that process. I'm trying to understand what power's been transferred though to community in the context of health system, health services. Yeah, what power? Is there any power being transferred over? So I get the resource component, which is what you clearly articulated just there, but power, which
I guess there are two bits to that probably. One is the partnership, the Health and Wellbeing Partnership Forum, for the moment, is our peak voice for all matters health and wellbeing for Aboriginal people in Victoria. So that's the forum in which the decisions are made about what should health and wellbeing care provision look like for community. No one else is making the decisions. But the second thing is, and it goes to my commitment in my opening statement about a commitment to increasing Aboriginal healthcare delivery in Aboriginal hands. How do we do that? And I'll give you just one, and it is a tiny granular example. But very early on in my role in 2021, Auntie Joel came to me and said, Secretary, it is a nonsense that our Aboriginal health practitioners are limited in the vaccines that they can deliver to immunise community. So we've changed it. We've changed our regulations so that our Aboriginal health practitioners now have a full suite of immunisation authority. So the authority to determine what the priorities are lie with the forum and the sector. And then I agree, it's up to the department to then respond to what those priorities are.
But the minister ultimately has overall say in that process though, right? Like if you don't have the delegations, the minister who has delegation, say for instance, they collectively decide that they want something, the governance forum or the partnership forum, as you call it, they don't get everything they want, I suppose is my point I'm trying to make. But they don't have ultimate power and authority.
Well, that is true. And that is true of the whole sector, right?
That's right.
And I think that's the journey that we're on as a state through treaty. And what will that look like as part of treaty? And what is the role of authorities like the Partnership Forum in treaty? Now, that will be determined by the First Peoples Assembly and the treaty process.
And whatever recommendations we make.
And the Commission, we stand ready to respond to that.
There's just got to be really clear from us around, we're trying to understand where self-determination is truly happening. True self-determination, not components of it. Thank you.
Chair, is that a convenient time to take the morning break?
Yes, I think so. Thank you.
So 10, 15 minutes?
15 minutes, shall we say?
Yeah, please.
Thank you. We'll adjourn for 15 minutes. Thank you.
Thank you, Chair.
Good to go.
Yes, thank you, Chair.
Thank you, Council. This session of Yoorrook Justice Commission, please.
Professor Wallace, I just want to come back to something that you acknowledged in your opening statement. You acknowledged that the traumas experienced by past generations remain visible today through the poorer health outcomes of their descendants. Speaking of First Peoples. And you said that this was both in terms of biological and social explanations for intergenerational trauma. Could I just ask you to explain what you mean by that?
Yeah, of course. And the Commission's heard evidence from others already about intergenerational or transgenerational impacts on health and well-being, and largely addressed the social aspects. And we've touched upon it this morning, principally through Commissioner Hunter, but around Aboriginal people not accessing healthcare because of not necessarily their own personal experience, but the experiences of their parents or their grandparents or their uncles and aunties, etc. Why would I go and have a baby in hospital if I know that others have had their babies taken away from them? So there's a social aspect, but there's actually a biological aspect. And actually the discoverer of this phenomenon is an Australian, Elizabeth Blackburn. She won the Nobel Prize for her discovery of something called a telomere. It's the very end of our chromosomes. It's like a cap that protects the very ends of our chromosomes. And as we age, the length of our telomeres gets shorter and shorter. And what Elizabeth Blackburn and her laboratory has gone on to show is that stress shortens telomeres. And there's work emerging now that telomeres of Indigenous peoples across the world, not just our own, have shorter telomeres. So there's a biological, and one of the impacts of shorter telomeres is that actually you age and you get diseases earlier in life. And so this is an emerging science. It's a science that I'm not, it's not my areas of expertise, but it is clear that there is emerging a sound biological basis for some of the health and well-being expressions in Indigenous peoples, plural, across the world, but of course our own Aboriginal people, because of the transgenerational traumas, the relentless stress that they live under since colonisation.
So,
Sorry, can I just add to that? Dr. Michael, I can't remember his surname, but he's a Canadian.
Michael Marmot.
No, there's another Canadian, done a Canadian study, and about being in culture and about meditation and being one, and the telomeres of First Peoples lengthened, which increased their life expectancy and protected against, which we already know, culture is a protective factor for our people. Sorry to give evidence there.
So fascinating new areas of science and understanding. You'd also be aware of changes to the individual brain chemistry through the impact of stress, cortisol, so on, and the impacts that can have on an individual's health and well-being.
Yeah, and not just on the individual. You referenced in opening my own research interests in my past academic life around fetal health. So it's clear that that a pregnant mother is under chronic enduring stress that impacts the well-being of her unborn baby and shapes the health of that baby as that baby grows up. So this is so-called the fetal origins of adult disease, first proposed by David Barker, a scientist out of Southampton in England. The placenta is a highly effective barrier. So placenta obviously belongs to the baby, to the fetus. It's a very effective barrier against the stress hormones that you reference, cortisol, from the mother. But in an environment of enduring severe stress the mother is under, the placental barrier gets overwhelmed. So maternal cortisol, these stress hormones, flood across the placenta and expose the fetus to very high levels of cortisol, when the natural state of the fetus is it has profoundly low levels of cortisol. How does that play out? Well, it plays out in high blood pressure, high rates of diabetes, high rates of obesity. The very things that we see in first peoples across the world have these biological bases.
So given that intergenerational trauma and the effects on chromosomes and brain chemistry, what does that require of governments in terms of the delivery of health services?
Well, I think first and foremost, it's about an awareness, isn't it? And again, I think you've heard evidence, principally from Professor Ray Lovett, but also others about how it's framed. It's almost framed that having high blood pressure and diabetes earlier in life is the fault of the individual, rather than an awareness and an understanding that actually there's biology at play here that is out of the control of the individual, that has been handed through generations past. We know from work from Scandinavia that the diets of the grandmother affect the health of the grandchild through transgenerational effects. So I think first and foremost, it's about an awareness that this transgenerational impact that has both biological and social components are out of the hands of the individual community that's alive today. And if we're going to make a difference, it's how do we reverse those effects? And it goes to, I wasn't aware of that evidence from Canada that Commissioner Hunter referred to, but we return to the ways of health and well-being that are traditional to community, because that is likely to reduce the stress and both with a positive impact on today's generation, today's community, but definitely on the health outcomes of tomorrow's generations. And that goes true for all people. This isn't something that's peculiar to Indigenous peoples, but the stress and the trauma that First Peoples live under since colonization is peculiar to them, specific to them.
Can I, sorry, Council, you've brought it up. So an example would be, and I'll get you to explain it so it's understood, a mother under stress, pregnant during the times of colonisation, and give it, say, 5 generations now. Does that still affect that?
I don't know the answer to that question. It is possible, and the work that has led principally out of Scandinavia, not uniquely so, but the reason the Scandinavians have led it is because they have data repositories that link that link every citizen, and so they've now got 3 generations of data on what was the weight of woman when she was giving birth, what was the weight of her daughter, what was the weight of that daughter as she was giving birth the next time around, etc., etc. So they have some of the more elaborate data systems in health and social outcomes, so they can interrogate in a manner. But in theory, the answer is yes, and there are plenty. I'll call them natural experiments of that show the power of the stress on the mother. So the most well written about are when pregnant women are pregnant during times of warfare, the Balkan War, or times of earthquake.
I would say colonisation was warfare.
So I was getting back then to colonisation. So what is the impact on those women and their children and their children's children, and to go to your point, the generations thereafter?
Thank you.
Professor Wallace, would you agree that science and that understanding create a positive obligation on the state to do all it can to reverse the harm to First Peoples?
Yes.
The physical and mental harm, and I might say psychological, cultural, spiritual harms. It's incumbent on the state to do all it can to reverse those harms.
Yes.
And do we know from the science how long it takes to observe those changes of reversal?
I don't know, and again, it's not my particular area of expertise. I don't know if it is known. It may well not be, because while this field, the biological component of the field rather than the social component, is relatively new and clearly informs proposed interventions, I wouldn't think we've had the generation time to see the impact of that intervention. In terms of human health and well-being outcomes, of course, the experimental fields use animal models to study these things, and there are animal models in mice, etc., that try to model exactly the same thing as mammals to see, and there may well be evidence from those experimental studies. It's just not my field of particular expertise.
Nevertheless, you'd agree it's something we absolutely have to look at.
Oh, yes. I mean, again, the
At least a couple of
attaining the
people.
highest standard of health is a fundamental human right.
And so that's the biological, and the social. We're talking about social determinants of health. We're talking about housing. We're talking about education. We're talking about
Employment.
We're talking about percentage of the population who smoke. We're talking about use of addictive substances. All of those things are critical features of the health of a person and their ability to achieve the highest attainable standard of health. Agree?
Yes.
Would you agree with all taking it needs to be a different approach for First Peoples to healthcare?
Yes.
And so, for instance, a good example is during COVID, during the epidemic, do you think we need to follow those steps of what was done then to have really good practice for First Peoples in this state?
Yes, I think Commissioner Lovett tried to get that also around what is it that was different and what have you learned. I think it's clear, and Dr. Luca gave examples from COVID about, well, firstly, that it was successful. The highest rate of COVID vaccination rates in Aboriginal people was in this state in the country. That wasn't an accident. It was healthcare delivered by Aboriginal people for Aboriginal people. So how do we apply that lesson to broader healthcare services? And taking the priorities as determined by the Partnership Forum, which is around prevention and early intervention, not to the exclusion of other things. Then how do we deliver that? That feels like the sweet spot. It's a community-based healthcare, health and well-being care. That feels like the sweet spot for Aboriginal-led providers, our ACOs principally, and others. And we will see improvements in acute outcomes. It won't be tomorrow or the day after, but in sectors that have done this, not in a First Peoples populations, but sectors that have done this. And there are some standout sectors in the US, I think of Intermountain Healthcare System, who essentially said, and it was largely for finance reasons, we can't afford this journey that we are on with increasing hospitalizations. Let's invest upstream. They turned around. So they've seen they saw a decline in acute hospitalizations for some core outcomes within 12 months and ongoing decline in hospitalizations. If we treat and manage diabetes upstream, we won't need to do amputations downstream. And that care, I think, is the sweet spot for ACOs.
Would you agree if we get it right for ACOs, we get it right for everybody?
Well, you go to, Commissioner, you go to a much broader point, and I did sort of reference in my opening statement about the WHO's definition of health and how that definition, that more holistic definition, should shape healthcare provision more broadly. So the short answer is yes. And again, it's not It's not that our health system has fundamentally failed. It hasn't. Evidently, it hasn't. It's been a system both in Scotland and in Australia that I've been very privileged and honoured to be part of. We have, as whole of population, some of the best health outcomes in the world, but they could be better. And they could be particularly better for some of our most disadvantaged populations, particularly our Aboriginal population in Victoria, but others also. And it requires additional spend on those populations, and it requires an approach that is fit for those populations, which goes to that holistic approach. So how do we listen and say, well, here are some of the issues challenging community. How do we best solve these? And let's do it in a self-determined manner.
There's probably at least a couple of PhDs in this, but if it took 5-6 generations to damage the cause of the damage, and we don't yet know how long it will take to repair the damage, surely a precautionary and protective approach would require significant investment in that research and in the work to address both social and biological aspects of intergenerational trauma.
Yes, I think if that is a priority for community, and I think the principal funding agencies for health and medical research in this country, NHMRC, MRFF, etc., rightly have dedicated Indigenous committees that determine where health and medical research spend should be spent. If that was determined to be a priority for community through those committees, then yes, I think that's a very sensible thing to do.
I know it's not your field of expertise, but just so those following can understand, there is a potential to restore health and well-being through culture, as Commissioner Hunter has pointed out, which can actually change brain chemistry even late in life. Agree?
Yes.
Do you want to explain those broad sort of mechanics?
It isn't my field of expertise. I think one of the and it has been not intentionally discarded or disregarded, and not universally discarded or disregarded by so-called Western healthcare. But this connection to country that is profound here is profound elsewhere. I have a very strong sense of my connection to particularly my mother's country. When we visit the UK with family, I always visit my mother's country. It matters to me. And as I stand in her country, I feel at peace with myself. That's what community has been telling colonizers, settlers for 200 years. But they've also been telling us that it feeds into their, fundamentally feeds into their health and well-being. And that's what I referenced, Auntie Jill's cultural arrogance. We've discarded it. And we've discarded it to the penalty of community. And we've discarded it to the penalty of healthcare providers, because I think, and again, my whole professional life, I've been surrounded by those who seek to provide care. They get up in the morning fundamentally to provide care, to look after people, to look after others, to make them better. Our doctors, our nurses, our midwives. I think and it goes to the sort of cultural safety training that the department has been funding through our health services. That is still in its infancy. But I think if our health workforce understood what matters to community, it would matter to them. How couldn't it matter to them?
What's the role of secretary in making that happen?
A lot.
What can you give us some examples of what are you doing as part of your leadership role to just kind of drive those principles as to what you've just clearly articulated?
Well, and I referenced a very tiny example this morning. Whether it's Auntie Jill, she's a fairly persuasive individual, as you well know. Whether it's Jill or Mick or others, whether it's partnership forum, say, secretary, these are the priorities for us. Then it's my responsibility with the department and with my ministers to try our best to deliver on those priorities. But it's more than that. It's a cultural journey. Our own department has undergone cultural safety training. It's about leadership in that space. It matters to me. And it's in small ways and large ways. We have in the department, we have a monthly all-staff forum. Aboriginal matters feature large in those fora often, because it matters. It's a real privilege to live in a nation where we have acknowledgements of country and welcomes to country at the beginnings of meetings. I have visitors who come from overseas, particularly from North America, who are blown away. But in the health sector, there's not just a willingness. And again, I think the majority of our workforce get up in the morning to serve the population as best they can. I think what's been missing is a visibility. Missing in part for me also. I have learned so much from listening to the evidence before the Commission over these past months. So much. So there's a lack of understanding of what are traditional Aboriginal and Torres Strait Islander ways of health and well-being, and how do we deliver those?
I mean, we are the first inventors and we're also the first innovators.
You are.
Can I just ask about within your department itself, where are your senior First Peoples bureaucrats? Because we know that visibility and that presence of the people who are at the decision-making tables every day, even when decisions are being made that people don't think will impact First Peoples, but usually do. What is the executive structure and the place of First Peoples in that?
So they're here in the room this morning. When the new department was formed, so end of 2020, we were the Department of Health and Human Services, and through machinery of government, we were separated into the Department of Health and the Department of Families, Fairness and Housing. You've heard from my colleague Peta from DIFA already. When we created the Department of Health in February 21, we've always had an Aboriginal Health and Wellbeing office. Previously, it sat in what was the predecessor division of Ms. Geissler's. I lifted it out of the division and had it reporting directly to my office and myself. Ms. McCartney, Nicole McCartney, is our Chief Aboriginal Health and Wellbeing Advisor. She sits at my executive board, along with deputy secretaries.
And all those people are First Peoples?
And Nicole is, yes, and below her she has two executive directors who are First Nations people.
Is that position a deputy secretary level position?
It's not.
Do you see that as potentially an issue, secretary?
Well, it's about functions and outcomes. I don't. I mean, I think, and maybe I'm the wrong person to ask. Maybe you should ask my Aboriginal Health and Wellbeing team if it's an issue. I think it's important for me that Nicole is present at board meetings. She's there as a full member of board. And it's a relatively small team, and I think in the information we provided in our response to requests for information, where we detail some of our workforce makeup, workforce structures. It's a team that's been around 24. It's currently growing to about 40. So it's a relatively small team for a deputy secretary level position. But in terms of authority, she has the same authority as a deputy secretary.
But I would say, Secretary, though, that the level of complexity from a non-Aboriginal point of view around, and it's not about Nicole, but it's about the position navigating, as well as the cultural load and the complexity that's associated with someone in that position. I would think, and I'd encourage you to maybe just consider that extra weight that your other deputy secretaries would not have to have. So, also, I understand that there's equity of voice, but there's also there's not equity of resources, if that makes sense.
No, it does make sense.
to the individual
Yeah,
and
no,
the
it-
team.
It does make sense. And there's a tension that we should call out, isn't which is that matters of improving Aboriginal health and well-being cannot be the burden of an Aboriginal health and well-being team. It has to be the burden of the whole department and the responsibility and accountability of the whole department. And I think that's exactly what Nicole and her team deliver for us, which is ensuring that decisions and policies and matters of improvement and investments are appropriately considering the needs of Aboriginal people in the state. But she has a broader role. She has a role in helping shape broader policy for health and well-being, not just in for First People. But I agree with you.
We might bring up now Section 9 of the Health Services Act, just following on from the discussion around intergenerational trauma. There is now to be introduced on the 1st of July a statement of principles, including a recognition of the fact of intergenerational trauma to be introduced into the Act, correct? And that those principles, the new Section 11E, do not affect the interpretation of the Act. They do not create legal rights and do not create entitlements to compensation. Are you familiar with that new provision?
Yes, I am.
And let's bring up Section 9 now. Perhaps if we could zoom in on A and B. Not sure if you have that in front of you. The panel had that in front of you, but the objectives of the Act are to ensure that under A, healthcare agencies provide safe, patient-centred and appropriate health services, foster continuous improvement, and B, an adequate range of essential health services available to all persons resident in Victoria, irrespective of where they live. And perhaps the other one that might be relevant is G, users of health services are able to choose the type of healthcare most appropriate to their needs. So you said in early on this morning that these were foundational expectations, they were not aspirational. Are these objectives adequate, given that the statement of principles don't guide and don't bind the department in a legally relevant sense? Are these objectives sufficient to deliver the highest attainable standard of health?
They're not explicit around the highest possible attainable standard of health. There may be merit in us reflecting on these objectives. I think the objectives remain fit for purpose today. Do they optimally serve the creation and delivery of a health system that delivers the highest possible attainable standard of health? There may be merit in reflecting on that question. So again, I think they very clearly and precisely, which is the intent of legislation, lay out what the requirements are of health agencies in the provision of healthcare for community.
But reference, for example, to an adequate range of health services, you would agree is not the same thing as aspiring that Victorians be the healthiest in the world.
No, I mean the one is to delineate provision of services. The other is the outcome, and as we've discussed already this morning, of course, for Victorians to be the healthiest population in the world requires much more than healthcare. In fact, healthcare itself probably makes up about a quarter of the contributors to health and well-being. And we've talked about social determinants and others before: good employment, housing, education, etc. So there are many things that make up being the healthiest population in the world that are out with the remit of health services and certainly health service legislation.
Okay. I just want to turn now to the Victorian Charter of Healthcare. If we could bring that document up as well. This is a document that we have, is dated 2016. Are you familiar with this document?
I am now, yes.
Yeah. And I understand it's been updated, but it's not the 2019 update is not available online. Do you know why that would be?
I don't.
if this document has been updated, you would accept that it should be publicly available?
Yes, and if it is available, we'll make it available to the Commission.
And will you make it available online?
Yes.
Okay. If we turn to page 3 of the documents, in terms of guiding principles, this is the 2016 document, so let's just work off this one, assuming it's still.
Yeah.
I think it's in the folder.
No, this document's not in the folder, so we have it available online. Thank you, Commissioners. The guiding principles include everyone has the right to be able to access healthcare, and this right is essential for the Charter to be meaningful. The Australian Government's committed to international agreements about human rights, which recognise everyone's right to have the highest possible standard of physical and mental health. And Australia is a society made up of people with different cultures and way of life, and the Charter acknowledges and respects those differences. So no explicit recognition of the standing and role of First Peoples under the heading of guiding principles. Do you know if that's still the case?
I don't. I assume that these are the current guiding principles.
Right, let's turn over to page 4, your rights in the Australian Charter of Healthcare Rights. And there are various dot points: access, safety, respect, communication, participation, privacy, and comment. And these rights all apply to all healthcare services in Victoria, correct?
Yes.
And can I turn to page 10, under the heading of respect? And you'll see there the right to be shown respect, treated with dignity and consideration without discrimination. Again, no specific mention of First Peoples under the heading of respect. Are you aware, Professor Wallace, of the evidence given to this Commission to the effect that the right to respect is and has been breached and continues to be breached?
Yes.
For First Nations peoples in this state?
Yes.
You'd be aware that the Close the Gap reports say as much?
Yes.
And you'd be aware of the evidence of Professor Ray Lovett that these breaches and the impacts of the extent, seriousness and persistence of racism and discrimination in the delivery of health services are serious?
Yes.
You would accept that the impact of that racism, or one of the impacts of that racism, is adverse health outcomes for First Peoples?
Yes.
And I invite your comment on whether we're meeting this Charter of Healthcare Rights for First People in this state.
I think evidently we are not. We're falling short of the Charter. The evidence that Professor Ray Lovett gave from the research that he and his team have done at ANU around experiences of racism are very challenging. Their whole of nation work. We have examples of our own in Victoria. So I think in VACCHO's submission to the Commission, they reference work from 2017 or 18 from RMIT reporting very high rates of experiencing racism in our health services by Aboriginal people. And the department itself, principally through Victorian Agency of Health Information, now VAHI, that's part of the department, has got a number of reports on patient experience of racism that led into a specific piece of work that looked at racism as experienced by Aboriginal people. So the first piece of work around experience of racism in a healthcare setting was whole of state, racism by country of birth of the individual, of the patient reporting it. And then out of that, pooled and created a dedicated report on health experiences by Aboriginal people in using Victorian healthcare system. And I think that the those data, both Professor Lovett's and others, and our own data, have been discussed before the Commission before. Something around the order of 1 in 5 people, Aboriginal people, report racism in a Victorian healthcare setting. That next to experiencing racism in general public, the next highest is healthcare setting, the very setting where you'd expect the rates to be the lowest. So I think the short answer to your question is yes.
When you say you expect that to be the setting in which racism experiences are the lowest, is that because those healthcare services are being delivered by trained healthcare professionals, or is there some other reason you would point to for that expectation?
Oh, the former. I mean, the healthcare at its heart is about helping others, and those who choose to train and work their professional life in that setting, I referenced it before, get up in the morning to do good. This is a fundamentally good workforce. People come to healthcare settings for help, to get better, hopefully, and for care. At the heart of care, it is hard to understand why experiences of racism are so high.
Professor, would you agree? I mean, and this is not the first document we've seen here at this commission, which is all about these values, but which invisibilise First Peoples, even though we know in all of those that Aboriginal people are heavily overrepresented. The fact that there is no mention of First Peoples in these documents, would you agree that that actually means that when people are reading these, it's failing to bring First Peoples and the prejudices, the discriminations, all the other things that First Peoples face to people's minds? So when they're thinking respect, they're not thinking racism and not making and stereotypes, challenging stereotypes.
I do. It is a missed opportunity, and I think the intent of the new statement of recognition to be inserted in the Act to be current from 1st of July is intended to correct that. So an explicit mention of First Peoples in the Acts. I agree with you. It is it's an omission. It's an important omission that misses an opportunity to highlight the lack of respect, racism, frankly, that leads to, it's a major contributor to the health outcomes. In one of the submissions before the Commission was the PhD from Monash I referenced earlier, which even suggested, and I'm not an expert in the field, but first reading suggested that racism was the most important contributor to poor health outcomes.
And yet I think many people from First Peoples communities would agree to say this continued absence of any mention of First Peoples in these foundational documents feels deliberate. It feels marginalising. It feels excluding. That it's not an oversight because it happens, the pattern is there. It happens again and again and again.
I hear that.
So what did you say the intent was of the Act? Is it the Act that's been changed?
Yeah, it's the statement of recognition that Councillor Sisting referred to in the two acts, Public Health and Wellbeing Act and Health Services Act. It's about an acknowledgement. I can read it to you if you would like.
We might see if we can bring that up
Yeah,
because we do
just
have.
wondering how that stops racism and discrimination in the system.
Well, it goes to the Commissioner's comment about the absence of an explicit acknowledgement of Aboriginal rights, Aboriginal people and their rights, and their right to access holistic care that meets their full health and well-being needs. The absence of that explicit mention.
Okay, that assists, right, in going forward.
Yeah.
So it doesn't stop the racism.
No, it doesn't stop the racism. And you've heard from Ray Lovett that requires a formal, structured, anti-racism approach to improvement.
So if we do have the document, which is the amendments to the Health Services Act, it's page 84 onwards. And just while we're bringing that up, are you familiar with the work of, you'd be familiar with the coroner's report last year into the death of Veronica Nelson and the highlighting by the coroner there of issues of racism and delivery of health services in a detention setting, custodial
Yes.
setting?
Yes.
You'd be aware that this wasn't the first time that there's been an examination of racism within the delivery of health services. So, for example, First Nations doctors groups themselves are reporting these matters. In Queensland, for example, the Human Rights Commission and I've forgotten the other partner with it now, conducted a baseline study using a tool called the Matrix to assess racism within the delivery of health services. You'd be aware of those tools and measures.
Yes.
So what steps has the department taken to address an anti-racism strategy across all health services in the state?
Yeah, I mean, as a whole of system approach from the department, apart from the investment in cultural safety training, the collaborative that Safer Care and VACHO and collaborative program that Safer Care and VACHO are doing together, we haven't imposed a matrix approach that the Human Rights Commission in Queensland developed. At individual health service levels, there are examples of work. Loddon Mallee, for example, have the Loddon Mallee Health Network have a piece of anti-racism work that they've been delivering with sense of good outcomes, falling rates of experience of racism. But the department itself hasn't led a piece of work yet on anti-racism.
The evidence, the nature of the evidence we've heard in this commission and the lived experience of those witnesses who come before the commission about the effect of racism, whether it's overt or whether it's 1,000 cuts, the minor offences, is that this is a significant inhibitor to good health outcomes, both in terms of presentation and trust in the delivery of health services, in terms of compliance with recommendations, in terms of the failure to take into account traditional ways of healing and practice, a whole range of issues that go well beyond having to deliver a baby on the veranda of a hospital. It is a persistent, continuous thread. And as you acknowledged, 1 in 5 people reporting experiences of racism in healthcare delivery. This is outrageous, isn't it?
Unacceptable.
And Commissioner Lovett asked what is in your power to do. What can you do about it? What will you do about it?
Well, again, we as I've just replied, we as a department, we have not to date done a piece of work on collecting purposefully collecting experiences of racism across healthcare system. The data that our own data that we have from Victorian Agency of Health Information derived from the Victorian Health Experience Survey from 2017. I think the data were published in 2021. And earlier this morning, I commented that 2023 collection of data are under analysis as we speak. So we will hopefully have another look at those health experiences, which includes reports of racism shortly. But I said this morning that I both thanked previous witnesses before the commission for the evidence that they had given, and said that we as a department, me as an individual and my colleagues and as a department, we've listened very carefully. It is clear that experiences of racism are profoundly affecting health outcomes for Aboriginal people in this state. Whether racism is the major contributor to poor health outcomes, it is certainly a major contributor. That rates of racism in our health services are unacceptable. The most recent data we have, 1 in 5. Half of Aboriginal people who report racism experienced it in a healthcare setting. These numbers are unacceptable. And I'm convinced by the evidence, and I've heard Professor Lovett speak before at the Aboriginal Health and Wellbeing Roundtables in Adelaide and Canberra earlier this year in Canberra. His evidence, his data, his research is compelling. And I am convinced that if we are to improve this, we need a purposeful approach, an improvement approach to do it. We need to collect the data purposefully, specifically. We need to report it in a manner that will inform improvements. And we need to design interventions that will be effective. We don't need to start from zero. I've referenced others, the Lord and Malley Health Network and their work, but there are others across our system that are already showing positive results in driving down rates of racism being reported within the service. I think the department does have a role in bringing that together and designing and delivering an intervention and hold ourselves and our services accountable.
And who else has a, yes, sorry, Dr. Looker, were you going to jump in? Who else has a role here? I mean, medicine, for example, is a very hierarchical structure. Senior consultants model poor behaviour, and trainees who might never have thought to have acted, you know, in a discriminatory way, assume that's the way to behave. Turning people away, inadequate treatment, inadequate investigation, all of these things we've heard about. So how do we nip it in the bud for those trainees who come with the intentions that you've described and learn bad behaviours on the job? Is that a role for the colleges?
Oh, yes, and our colleges, yes. I mean, our colleges are stewards and curators of training programs for medical specialists, for nursing and midwifery and allied health professionals. I think I'd say two things in response. First, we do need to collect the data in a meaningful manner and a timely manner. So intermittent health experience surveys every 3 or 4 years are neither timely enough nor granular enough to tell us where are those experiences being felt. So the fact that nearly 1 in 5 Aboriginal people report experiencing racism in healthcare doesn't tell me where that is. So we need to build a system of data reporting, which is not rocket science, that we can see it in near real time, and we know where it's happening. So we can then work with the health services in support of removing it.
I think this comes to the point, Secretary, as well, that we raised in housing where 1 in 5. So you're talking about 1 in 5 Aboriginal people experience racism. 1 in 5 Aboriginal people experience homelessness. Homelessness. Now, if you put that in mainstream figures, that would be 1 million people in Victoria experiencing racism. 1 in 5. Like, it's a lot of people. Let's talk about tangible numbers here.
It's 1 in 5 Aboriginal people experiencing racism in Victoria. So our Aboriginal population is about 65,000.
Yeah. But if you're looking at it in the context to non-Aboriginal people,
yes,
that would equate to 1 million people.
Yes. Of course, the rates of
what we're trying to highlight here is that's still like 1 in 5 is still a significant proportion of our people experiencing racism.
Yes.
Whilst we have a small amount of a population, because if we go to, it's only 1% or 3% population, it diminishes the importance of 1 in 5 people experiencing racism. That's the point I'm trying to emphasize here.
And those who are reporting that fact. So the number could be well higher.
Yes,
Could well be higher.
considering those that'll even turn up in the first place.
yes.
So can I invite all of you to, if there are any other responses you have to this issue, before we drill down into the data a little, are there any other responses to this issue of racism that you would like to highlight for the Commission and how we deal with this?
And I mean, I think it's correct that there's obviously an urgent need for focused attention on the racism in health services. I think what is also apparent from the evidence that's been given at the Commission, and I think to all of us in our understanding of the issue, is that it also reflects a much broader approach of society. So the people that are working and the systems that they come from in health services are drawn from the rest of the population. So there is an absolute critical need for action on racism in health services, but of course it also reflects, I think, the much broader issue of attitudes across our broader population and
So-
lack of understanding.
So a respected journalist was recently held up and rebuked for saying the word racism at a writers' festival recently. What does that say about our maturity and our ability to discuss this issue that you are seeing in the delivery of health services?
Yeah, I think, Laura Tingle's experience is instructive about us as a nation. The other thing I was going to say was that for 25 years, I had the privilege of being involved in teaching medical students and junior midwives. They are not at their origin a racist workforce, in my experience, and had the privilege of teaching in Monash's medical school for more than 20 years, with a very, very diverse origins of medical students coming through Monash. We have, it's not unique to healthcare, but the experiences that are expressed through the Victorian Health Experience Survey that we've referenced today, and that the data that Professor Lovett presented to the Commission from his work at ANU, tell us that we have a healthcare system that has racism systematized. And again, to go to his evidence, it needs a formal, structured approach to remove it. At its core, it's people do not, my experience is it's people do not enter the workforce as a racist workforce. But again, the broader horizon of Laura Tingle's experience, I think, is instructive for us as a nation.
But what changes them then? To go on your lived experience, which is very different to my people's lived experience, what happens when they get in that system then? If they're coming in genuine, wanting to help people, which I can understand where you're coming from, but from a system point of view, why are our people, 1 in 5, being treated this way? It doesn't, like, I'm trying to translate your response to the lived experience from our people, and it's not anecdotal, it's actually evidence. A lot of time in Aboriginal affairs, it's just how we see and feel the world rather than this is data. This is a mainstream way of capturing evidence, data, and yet I'm just trying to reconcile your response then to the system itself.
Oh, Chris, I love it. It is a complex answer, I think. If I might just step back for a moment, over the last decade, there has been a movement in healthcare improvement more broadly called What Matters to You. And it's about teaching healthcare providers, whether it's doctors or nurses or physios or whoever they are, to ask the question to the patient in front of them, what matters to you and then try to meet that needs, rather than bringing to them what they think is matters to the patient. It goes to the comment this morning around, my comment this morning around the WHO's definition of health and health care, that it's a holistic approach. And it's complex. I think for our first peoples, that holistic concept of health and well-being that is grounded in country is not understood by the majority of our healthcare workforce. And so rather than asking what matters to you, they bring, because if you ask the question, what matters to you? Well, this is what matters to me. It matters to me that my auntie can come into the birthing room with me, or whatever it is.
I'm still trying to grapple with like the system though, Secretary, because people created these systems, not our people. They were created by people. And I understand you're saying that people are coming in with goodwill and intent from their training and they're getting meaningful training. I'd probably question that, but I didn't go through the level of educational that you did and others around to become a doctor. But I'm just trying to understand people going in, with the right mindset and the intent, but then when they get in there, it's the system's not changing, but people created these systems. And how you change a system is not from robots. People need to change the system back or enhance it and so forth. So I'm still trying to understand the actual, how is the system so wired against Aboriginal people still,
Dr. Look,
I'll just make a quick comment. I think there is a fundamental element of the biomedical model that is delivered by healthcare, which directly or perhaps inadvertently, but some would argue directly, excludes that holistic understanding of health. So you can have good people trying to deliver a Western model of medicine and measuring outcomes by that, but it is that's naturally then where the focus goes. And I think that's at the exclusion of all the other critical elements of wellbeing that are not considered. And I think then when they're such a fundamental part of somebody's a first person's experience of wellbeing in a hospital, means that that's excluded and not met. So I think there's a fundamental aspect of Western
I can
medicine.
understand that. But I come back to, sometimes our people need to come to the hospital for a particular thing they want to get sorted, and it's not all caught in the spiritual side of our culture and our country and our connection, because that can be lost. I'm not saying that's not a key part of it around our healing, but the fact is they have a matter that they need to get dealt with, and they're turning up and they are treated with racial behaviour. It's kind of what I'm trying to understand, is that we turn up, we need this level of service because it's a human right to talk about all your opening statements. It's basic human rights. I'm not talking about cultural rights. I'm just talking about human rights to get meaningful and effective healthcare or support, because that's what we need. And that's what I'm trying to understand, the system. Let's not get too caught in the cultural side of things, because we can get to that, but just service delivery, basic service delivery. I'm being treated with racial behaviour. That's what I'm trying to understand.
Ms. McLeod, we've got only a few more minutes left, and
I still want a response to my question, Commissioner.
I don't have an answer, Commissioner Lovett, for you this morning. I don't understand why nearly 1 in 5 Aboriginal people have experienced racism in healthcare delivery in this state. But we need an approach to sort it.
yes, Ms. McLeod, we've only got a few more minutes left.
Yes, thank you,
Building
Commissioner.
on this discussion, obviously one way of dealing with the question of racism in the system is to devote resources to ACOs, correct?
Well, yes. I mean, I think increasing Aboriginal health and wellbeing care provision into Aboriginal-led providers' hands would improve that.
Exactly. So in the material that you've provided to the Commission, as I read it, in this last financial year, the percentage of the departmental budget directed to ACOs was 0.2%.
Could we bring up, please, Annexure B to the RFR response? The reference for the transcript is DOH.004.002.000
Next
Seven.
page.
7, 6 and 7.
Is 0.2% devoted to ACOs, which you said would at least address in part this question, but obviously others. Is that sufficient?
I think, and I understand how you've derived the 0.2% in the table. That's 0.2% of the whole of the department's budget.
Mm-hmm.
I'm not sure that's the right. I understand highlighting that number. I'm not sure that's the right comparator. So the function of the principal function of ACOs is to provide primary community-based care.
Mm-hmm.
So if you look at the departments, the proportion of the department's spend in that space, in that primary and community care space, so ACOs and community health services, mindful that the majority of primary and community care investment, health investment, is by the Commonwealth. But if you look at the proportion of the department spend in that space, then it's about somewhere between 4 and 7% is on ACOs. So if you just take the primary and community spend and say what proportion of that is to ACOs, across the 2 years that we provided data for, it's between 4 and 7%. The majority of spend, of course, is in mainstream hospitals. But that's not a sector that ACOs are providing care in, notwithstanding the comments we've made already this morning, which is about trying to move care out of that sector into the home. And could ACOs play a component, a larger role there? I think the short answer to that question is yes. But if we just focus on what proportion of department spend in the community primary care space, the proportion to ACOs is somewhere between 4 and 7%.
Could we just go back to table 13 for a moment on the previous page and focusing on the column for ACOs for 2022-23 and 23-24. We see there, so the total spending across ACOs, community health and mainstream hospitals for each year is around $20 billion, correct?
Yes.
If we look at ACOs, you see in the 22-23 year, the vast majority, just over 50% of the spending on ACOs for 22-23 was by way of fixed term 1-year contracts.
Yes.
With so that's around just a little over 50% of the total spending for ACOs is spent on fixed term 1-year contracts. And then for 23-24, it's less than 10% of the total. You see that?
Yes.
And so I understand that reflects the huge boost or surge funding that was spent during COVID, which has now been pulled back.
Yes, and largely, I mean, not uniquely, but the majority of that change in funding, both to ACOs and it's evident also in community health services, in 22-23, that's not present in 23-24, reflects our investment in 22-23 and the prior year for that matter, specifically on COVID matters that has then come off.
So we've heard evidence around the impact of those fixed one-year contracts and the difficulty for ACOs to retain staff when they're on these short-term contracts.
the shortfall in the workforce for VACOs, do you know the numbers of the workforce shortage for ACOs across Victoria? Is it around 500, 600?
I don't know how many vacancies our ACOs have
Hmm?
this morning. I don't have that number in
It
front.
wouldn't surprise you if those numbers were high, given the funding for short-term contracts versus ongoing projects. Correct?
Certainly short-term funding projects does not encourage and support enduring employment.
Council, could I just ask another question?
course,
more,
Chair.
just slightly different from talking about what the ACOs are doing and how much money they're getting. What about the training of the people that are working in the hospitals now to work with First Peoples and people from other culture? Is that the same as it's always been, or has that been stepped up given the COVID experience? Because there's a lot of burden on the organisations who already are stretched and experiencing staff. But what about mainstream staff who need to be trained to work with our people to understand the cultural differences and the way to do things better?
Commissioner Burke, we haven't explicitly stepped up funding for training to work with Aboriginal people or Aboriginal sector. There is explicit funding for our health services. 38 of our health services have explicit funding around cultural safety training. So there is funding that we have identified specifically for that. But in coming out of COVID, have we developed funding streams to increase training for the mainstream workforce to work better with ACOs, or we haven't?
Well, I'm thinking about the patients and the people that pass through, because I can testify that there were many mistakes made during COVID.
Mm.
So the two questions I wanted to ask you about this comparison between 22-23 and 23-24 is, first, we see a winding back of the funding of ACOs generally. Has that funding simply been reallocated within the health budget?
No, so and I don't think so. I think I don't think we should interpret this as there's been winding back of funding for the ACOs generally. And if you look at both the multi-year and ongoing funding lines between 22-23 and 23-24, there have been increases in both of those funding lines.
Mm-hmm.
I think the big swing between fixed term 1 year for 22-23 and 23-24 is almost entirely explained by COVID dedicated funding coming off, given that the needs for that funding have largely gone. So there'll be tail end funding for testing, for vaccines, for educational support, etc., etc. And you can see it evident also in a funding change in the same funding line, fixed term 1 year for community health services, and to a much lesser extent for mainstream hospitals. Again, I referenced this morning that there was significant investment to mainstream hospitals during COVID to respond to COVID, and that funding has come off as we've returned to a more BAU and we've created system capacity and capability. So I think it would be wrong to interpret this as funding for ACOs is diminishing. It's not. And then the other element to this is, and we've talked about it earlier this morning, is that through the Partnership Forum and through the advocacy of VACO, we've heard very clearly that single year funding just does not work for the ACOs. And so they much prefer multi-year funding, and that we are now making those changes. We're doing multi-year funding contract with VACO itself and looking to how do we now take a similar approach to ACOs.
Can I it just strikes me looking at this, so that the reduction from 56 million to 3 million is a huge reduction. And while there's little bits of reduction in your community health service and your mainstream hospital, it's nothing like the reduction that's occurred in all the reduction is in that first year, and it sort of doesn't seem to have gone into longer term or fixed or ongoing funding. It just seems to have disappeared completely.
Yeah, and again, I think that it's because the funding is principally for COVID-facing functions, that this was the last year, 22-23 was the last year of the COVID-facing functions when and we've talked about the successes of the COVID response for community delivered principally by ACOs and others. But so I think that swing is a reflection that those functions are no longer there, they're no longer required, those COVID-facing functions.
I guess my point is that the reduction from community health services, if we were to do a comparison rather than hospitals, doesn't seem to have gone down to anywhere near the same extent. And obviously, they also had COVID boost funding.
Yeah, and I think they did, but I think it reflects that the particular investment that government made in ACOs to deliver the services that they needed to deliver for community during COVID, and that there was a proportionally larger investment in the ACO space than there was in the community health space.
So we saw a rapid scale up within the ACOs to address the COVID response, particularly for the fixed term 1 year contracts, which has now been scaled back significantly in the current year budget, correct?
Yes.
And this was a highly successful response, as we've heard.
Yes.
So what is the significance in terms of the loss of that workforce and recruitment and retention of that workforce if there is no adjustment to the multi-year and ongoing funding of the workforce? We simply lose all those people.
Not entirely. Many of them will have left, but not entirely. If we look at the combined of multi-year and ongoing funding in between the 2 years, there's been a significant increase in funding between the 2 years, with a particular increase, and not quite doubling, but not far from it, of multi-year funding, again, reflecting what we've heard from BACHO and from ACOs, that there's strong preferences for multi-year funding programs.
So the multi-year has gone from close to 4 to around 6, but nowhere near making up the difference between fixed term 1 year, 56 down to 3, correct?
No, correct, because the need for that, the functions of that 56.5 million fixed term 1 year contracts were supporting were COVID facing functions.
Yeah,
they were no longer needed.
I understand that. My question is around workforce.
Yes.
We had a skilled workforce stepping in in a very successful way to fulfill this function during COVID, and there's simply no funding for them. So what does that do to the workforce in terms of their willingness to come back and work in the space, in terms of our ability to recruit people, in terms of the ability to deliver services through ACOs that we know are successful as a successful model? We've lost that workforce, haven't we?
Not entirely. They won't all be on workforce. There'll be a decent proportion on workforce, but some of that will be around buying vaccines for our ACOs to give vaccines, testing equipment, etc. And it may well be, I referenced our Aboriginal health practitioner workforce before, and expanding their ability to deliver now a whole array of immunizations of vaccines, but during COVID to give COVID vaccines. They can still give COVID vaccines, but of course the volume of COVID vaccines and the hours they need to be doing would be much less now.
So this funding line for 22-23, and presumably the 2 years before that, that fixed term 1 year contract includes the purchase cost of COVID vaccines, does it?
It'll include all sorts of things, yes.
So I'm just trying to understand this. As between the Commonwealth and the state, the Commonwealth purchased vaccines for use by the states.
We shared the costs of vaccines 50-50 through a national partnership agreement.
So at first instance, the Commonwealth secured those purchase orders.
Yes.
And shared the cost of purchase with the states.
Cost and distribution, yes.
So how does the cost then become a line item for the ACOs?
Because that's the money that we would provide ACOs in terms of providing those vaccines.
Were they literally putting their hands in their pockets for the vaccines, or was that this just a line item to represent that the ACOs were delivering that service?
We were funding through the National Partnership Agreement with the Commonwealth. The
Yes.
state was funding 50-50 cost of vaccines and vaccine delivery.
Yes.
And if we had in terms of, and it's not, this won't be uniquely our vaccine program, but in terms of the vaccine program, we had a dedicated vaccine program for community, largely, but not uniquely, but largely delivered through our ACOs. The cost of that vaccine program would be in part reflected in that line item.
Any questions about the funding, commissioners? I did want to touch on the targets before we move on, but yes, Commissioner Hunter. Medicare, just before I leave funding entirely, Medicare is funded by the Commonwealth, correct?
Yes.
In terms of services provided within custodial settings, Medicare is not available.
No.
So that means the state has to step in with health services in custodial settings.
Yes.
And you've heard evidence, no doubt you're aware of the evidence about the inadequacies of the delivery of health services within custodial settings.
Yes.
What are you going to do to fix that?
I'm not in the custodial healthcare delivery is overseen by my colleagues in Department of Justice and Community Safety. So custodial health is a program that sits in DGCS, not in Department of Health.
Should it be within health?
That's not matter for, it's a matter for government.
No views in terms of who's best placed to deliver health services to those of our most vulnerable people in custodial settings?
Oh, I'm not able to assist the Commission on that matter this morning. It's a matter for government.
We might ask the ministers. All right, leaving funding then and just quickly touching on targets and data. You said that if you can't measure it, you can't improve it. And so I just want to touch on the measures and data before we finish. So in addition to, there are 4 principal close the gap targets that are relevant, correct?
Yes.
We have, not sure if we've got the document, but we have long and healthy lives, which is life expectancy for males and females separately maintained. Is life expectancy currently reported for Victoria for First Peoples?
It's not.
And could you just explain why that is?
Yeah, so two things here. One is that the closing the gap measures and reporting is a national program. The data that go into those various measures, but including life expectancy, in the case of life expectancy, come from the Australian Bureau of Statistics, ABS. So ABS data that are derived from the states and territories, collated by ABS, then go into closing the gap. That ensures a uniform approach, make sure that like is compared with like, etc. It's appropriate. ABS have determined that the size of the population, the Aboriginal population in Victoria, and the number of deaths in that population are too few and unstable to provide reliable estimates of life expectancy. So in order to calculate life expectancy, you take in every year of life, take the number of the population in that year of life and the number of deaths, and then calculate for every year of life, and then bring them all together to give us an average life expectancy. ABS has determined that not uniquely to Victoria, South Australia, Northern Territory, Tasmania, the data are too unstable and unreliable to provide data for closing the gap.
So do you interpolate from that data the position in Victoria, or is there another trusted source that you could look to for that information?
Yeah, so we can't extrapolate from closing the gap because our data aren't there. Clearly, the 8 to 10 year average life expectancy gap between Aboriginal people and non-Aboriginal people, both men and women, we would not expect to be very different for Victoria, but we cannot extrapolate. Is there another way to do that? We are working both with our own data agency, VAHI, but also we were required to work with birth, deaths and marriages, the holder of these data, could we develop a workaround, if you like? So to report ourselves, I don't think it would necessarily provide the reassurance that ABS would want, but it might. And I think the answer to that question is yes, we want to be able to report life expectancy data for our own population.
So the states and territories who are not included because of the sample size are, you said, Victoria, South Australia, Tasmania and ACT. So accumulating that data would still be useful in terms of urban populations, regional populations compared with remote and very remote populations?
It might be. I think that would be a matter for ABS to determine if there's validity in doing that as a collective jurisdiction, as it were. And again, it's not an area of my expertise. I think the data scientists in ABS would be best placed to decide, is that a useful sort of second line approach?
So Dr. Looker, can I invite your response as well? Life expectancy is obviously a key measure for delivering of health programs and measuring successful outcomes. Would you agree?
Oh, definitely.
So do you have any ideas how, from a public health perspective, we might capture that data and measure success against it?
Look, I think I'd agree with the Secretary. There's a need to do that and to look at the other data sources that we are routinely collecting to see if there's another way of getting that understanding of the Victorian experience. I'm not across all the available data in enough detail to sort of propose a methodology for that, but I definitely support its development. Yes.
I mean, there are, sorry, Council, there are other, so lying underneath these so-called principal measures, there are supporting measures, and
yes,
the supporting measure for life expectancy, there are numbers of health checks per head of population. We do have those data for Victoria. And comparably, there are fewer health checks per 100,000 population in Victoria than there are for Aboriginal people than there are for other jurisdictions.
and what do you make of that?
Well, it goes to the conversation we've had earlier about the need to invest in prevention, early intervention. Partly informs decision of government 2 budgets ago about investing the closing the gap, the urgent care pathways, about providing additional and specific funding to ACOs to deliver prevention, early intervention, those very health checks. And actually the only measure, if you like, of the performance of those urgent care pathways is the number of health checks.
The second close the gap target is children are born healthy and strong. So this relates to the proportion of babies with a healthy birth weight. The gap here, I understand, for Victoria has not moved beyond around 90% compared to around 94% for non-Aboriginal people for around a decade. Is that correct?
It is no, well, it is about 90%. It is getting better, so it is improving year by year. It is, as assessed by the closing the gap, it is on target.
On target?
Yes.
To reach equivalence?
Yes.
And what are the things that are succeeding in terms of lifting that target
Well,
in Victoria?
difficult to say. There are lots of things that feed into having a baby with a healthy birth weight. We touched upon some of them this morning. In Victoria, for just over 20 years now, nearly 24 years, we've had a Koori maternity service. And it's difficult to say whether what the precise impact of the KMS has been on pregnancy outcomes, including healthy birth weight. I think it's been significant. So the other measure, it's not part of closing the gap, is the so-called perinatal mortality rate. So the number of stillbirths and early neonatal deaths in among Aboriginal women and non-Indigenous. And the rate for Aboriginal women, so perinatal mortality in Aboriginal women, has almost halved in the 20 years that the KMS has been running. I think, and you know, can you point to that and say that is causative, or it's just an association? It's difficult to say it's causative, but I would be surprised if it wasn't. And so I think the improvements in healthy birth weight, and we have, as a jurisdiction, we have one of the best target 2 healthy birth weights and progress in the country, I think is in large part due to our KMS.
And the third rate, and I do not mean to depersonalise this by reference to statistics, but target 14 concerns the number of people who took their own life. And Victoria does not keep data on this issue, and just noting there's no trajectory for this one because there's no acceptable rate of suicide in the population. So a recognition that this is a difficult one to target in terms of outcomes, but Victorian data is not kept on this. Is that correct?
Not kept centrally. It's very difficult, and like you, Council, it's important not to depersonalise this. There are lives and families at the centre of this number, of this target, and any death by suicide is unwanted. The coroner, as you know, keeps data on Aboriginal deaths by suicide, and from time to time issues a report. There are no central data collections currently for this. And the target really is there is no gap between the rates should be the same between Indigenous and non-Indigenous populations, as low as possible.
I did want to. Yes. Okay. Yep. I did. We're up against time, but there are also measures under the Victorian Aboriginal framework, various health and wellbeing domain measures that are measured, some of which are improving, some of which are not. Is there anything you wanted to say about those measures, measure 11, 12, 13 and 14, in terms of the goals set under the framework and at a high level?
No, I think, there's a fairly extensive suite of measures, some 27 measures across those goals, and also in domain 1, which is goal 1 around children, family and home. I think there are, in many of those measures, there is good improvement, but in far too many, there is insufficient improvement. I think they point to us, they're a comprehensive suite of measures. They point to us where attention needs to be paid. They also highlight rates where there have been successes, and ask us to be curious about why they've been successful. We've had some of those conversations this morning. So, for example, rates of immunisation of Aboriginal children are higher than for non-Indigenous children. What a wonderful success. Why is that? Why have as a state we've managed to deliver that? And it goes back to the same findings that we've discussed this morning, that in large part we have put the care of and the responsibility for those immunisations in the hands of community, of Aboriginal-led services. But there are others, there's still a gap, an unacceptable gap, but there's an increase, there's a narrowing of the gap of uptake of breast screening among women 55 and older. Why is that? Well, it's in Aboriginal women. Why is that? Well, it's for initiatives like the Beautiful Shaw Project and the Possum Cloaks that make Aboriginal women feel safe when they come forward for breast screening. They know they're going to be cared for. So how do we remain curious about the measures that we've seen improvement on and continue to see improvement, and not just say, oh, well, that measure's done now. It's why did that measure succeed when these other measures haven't, and apply the lessons learned to those that haven't.
I really don't want to brush that conversation, but I'm mindful of the time. Is there data that you could be collecting on service utilisation and equity of health outcomes that you're not currently collecting?
Oh, I think the short answer to that question is yes, but I think actually this suite of measures, 27 or so measures, is probably sufficient. There's a risk that we spend time creating new measures rather than time improving care and care provision. So there are measures around service provision and service access under Go 12. There's a whole suite. There's 5 measures around Aboriginal Victorians accessing the services they need, the proportion who receive a health check. We've talked about rates of cancer screening, both breast cancer, cervical screening, bowel screening, proportion accessing disability services, etc., etc. And actually, just I mentioned cervical screening, the introduction of self-testing. So women taking the swab themselves in the last couple of years has seen a profound increase in cervical screening among Aboriginal women. So self-testing, 3 years ago, self-testing was 1% of all cervical screens taken. 99% of cervical screens were done by a health practitioner. Within 3 years, that is now touching 30% of cervical screens are self-tested. And we're on a trajectory where very shortly the vast majority of cervical screens will be done by the woman herself. The biggest increases in uptake of cervical screening have been in previously unscreened populations, including Aboriginal women. So Aboriginal women will be having rates of cervical cancer detection or pre-cancer detection that have been previously unwitnessed in this state. Why? Because we've made care accessible and safe for the woman. It's not rocket science. So there are significant lessons for us to learn for the improvement in many of these measures that we need to remain curious about. What is it that's driven those improvements that we can now apply to the others? And I think the health checks, and again, the investment the government has made in the urgent care pathways for Aboriginal community is to improve the provision, the capability and capacity to provide health checks, particularly for middle-aged and older Aboriginal men. Come forward and get your blood pressure, et cetera, done. And I would hope that against that measure over current years, as the ACOs roll out their expanded services, we'll see those numbers lift. And we will ask the question again, why has it worked? Well, it's worked because care felt safe, and so people came forward to receive it.
I'm going to ask commissioners whether they have any further questions in a moment, but is there anything further you would like to add to the evidence, the discussion we've had today, or any reflection on the examples that the commissioners have raised for each of you?
I think that thank the commissioners for the time this morning, but we've heard individual stories from both Commissioner Hunter and Commissioner Lovett of their own recent health experiences and family, and we want to acknowledge. Thank you for sharing those deeply personal examples. They're a reminder of the deficiencies in our system.
Dr. Geissler or Dr. Looker, anything further you want to add to the discussion we've had this morning?
No, just a thank you for having us.
Commissioners.
I have one thing. I heard at a recent forum, as you know, a lot of First Peoples do not identify when they go into a health setting, and they do that for reasons of safety. I heard at a recent forum a plan to actually data link with other data, such as education data, to get around the fact that people aren't identifying and increase the numbers of people being noted on health records. I want your reassurance that that will not happen, that First Peoples' right to identify or not identify is maintained, and they do not have that choice taken away from them.
It's a very complex issue, and I don't want to oversimplify it. We have a whole of government approach to data sovereignty that government is committed to, and the department is part of that commitment to data sovereignty. It's very, very important. There are two bits to what you've said. One is an individual's right that needs to be protected to either self-determine or otherwise as an Aboriginal person. But the other bit is that in the data, we have those data that that less than half of Aboriginal people are asked whether they identify as Aboriginal or Torres Strait Islander. That's not acceptable.
No.
So everyone needs to be asked. It is their individual's right to determine whether they wish to reveal that or not. I agree. We have seen an increase in self-declared Aboriginality in Victoria in our health system. I think that is a good thing, because I think it reflects that people are feeling safer, nowhere near safe enough. And knowing the proportion of people who identify and choose not to identify, I think is useful. It's how do we get that data? Because if the proportion of Aboriginal people using our health services in Victoria who choose not to identify as Aboriginal or Torres Strait Islander, if that proportion is high, I think that is telling us something about the cultural safety of our service. So I agree with you. It is an individual's right that should be protected. And it's how do we get those insights that help us shape, they improve the service.
Not use data linkage to get around people's personal choices.
Yes. One about board appointments. Who appoints the board at these hospitals?
Oh, sorry, you go.
No. I'd like you to answer that,
Yeah,
please.
and it does come through my division.
Yeah.
So these are cabinet processes.
Yep.
We have quite an extensive recruitment process and we put up suggestions to cabinet and they approve
Yep.
the appointments. I'm really pleased to share that we've seen significant improvement between this current financial year and next financial year in terms of representation of First Nations people on our health service boards. It's critically important that that representation occurs across the organisation. And next financial year, I can share the data with the Commission, but next financial year it will double.
Okay. And how long is the tenure?
So it's 3 years. 3 years.
For your appointment. All right.
And sometimes they cycle over if
Yep.
an individual so chooses. Yes.
Okay. And is there gender parity already?
We do look at gender parity. I don't have the data on gender parity in terms of our representation from First Nations people,
Yep.
but I can get that data.
Okay, thank you.
I'm just following up on those. So we've got the numbers. As at 30th of April 2024, the department has 26 staff that identify as First Peoples, or about 1% of the workforce. Is that right?
That's right.
And about 1.1% are in leadership positions.
That's correct. And we're committed, like other government departments, to having both of those proportions at 2%.
In terms of the public health workforce, 0.39% of Victoria's public hospital workforce, or around 574 people, identify as First People.
Correct.
And hopefully soon a deputy secretary.
Is there a formal process for recruitment and retention?
In the
First Peoples?
department or in the health sector?
Both.
Well, we are expanding. So we have a commitment to proportion within our own department and have processes to deliver that commitment. And as Commissioner will be aware, all government departments have gone through some changes over recent time in their workforce. Our Aboriginal Health and Wellbeing team is expanding, so we're on track to increase to 40, which will take the team to around 2%. As opposed to sector, we have both and shared with VACCHO an Aboriginal Health and Wellbeing workforce strategy and a broader health workforce strategy belongs to the department, in which there are specific actions to increase the proportion of Aboriginal people in the health workforce.
Here's your opportunity, Secretary, to make a plug for workforce.
It's very important. I mean, in terms of the workforce, if we even if we increase the provision of prevention and early intervention care into Aboriginal-led care providers, increasing the capability and capacity of our ACOs, our Aboriginal people are still going to need to access mainstream services. They need to be culturally safe places for them to do so. And in helping that, we should increase the number of Aboriginal people who are in the workforce. Now, it has increased. It's increased almost tenfold over the last decade. But to get to 1% will require another 500 to 600 people coming into our health sector workforce at a time that everyone knows that the workforce, the sector, is very challenged in terms of vacancies, nurses, midwives, physios, etc., doctors, etc. We have a number of programs of investment specifically targeting Aboriginal people to give them work experience in cadetships, for example, to support them on our midwifery and nursing scholarship programs, as another example. This will require a concerted effort from us as the department, from our health services, from VACHO, and from others tertiary providers. It is no small task to deliver a proportionate Aboriginal workforce in our health workforce. 1% would require, again, another 500 or 600 people. To get to 2 or 3% would see that the health workforce is actually employing 1 in 10 of all Aboriginal people in the state. Let's get to 1%.
Commissioners?
I have a number, but questions, but I'm really mindful of time. So if I can put them in writing,
Of course.
be best. Yeah.
Other commissioners? Thank you very much to the panel for your time this morning and for staying over time. Could we resume, please, Chair, at 2 o'clock for the Minister and Deputy Secretary? Is that sufficient? Yep.
Can I just make people aware of 13 Yarn for any evidence that was given today that people are feeling not so great about or unwell, and to reach out to their services if required.
Thank you, Commissioner. Okay. No, that's fine, Commissioner. No, they're all good.
Chair. Thank you, Chair. I understand that my appearance has been announced, but I would like to acknowledge that we continue our hearings on the unceded lands of the Wurundjeri. My learned friends will announce their appearance.
Thank you, Chair. Ms Coghlan, I appear for the State of Victoria today with Ms Batten, and we appear for the Mental Health State Witness Panel, which includes the Minister for Mental Health, Ageing and Multicultural Affairs, Ms Ingrid Stitt, and also Deputy Secretary, Mental Health and Wellbeing Division, Katherine Wellbeing. Thank you, Commissioner Hunter, for your welcome this morning. We weren't here to hear it in person, but we did watch it online. We acknowledge that today's hearings are held on the lands of the Wurundjeri people. We pay our respects to elders past and present, and we also acknowledge, of course, that sovereignty was never ceded. We pay our respect to other Aboriginal elders and also any First Peoples who happen to be here today or otherwise watching online.
Thank you, Chair. Before I ask the witnesses to give an undertaking to tell the truth, I would just highlight for everyone in the room and anyone watching that some of the topics we will be discussing in this section will be sensitive. There will in particular be a discussion of and focus on the quite concerningly differential suicide rates. And so I just warn for some viewers that may be upsetting. Welcome, witnesses. Minister, I'll swear you in first. Minister Stitt, could you please tell the commissioners your full name?
Ingrid Stitt.
And you hold the position of Minister for Health?
Mental Health.
Mental Health. And is the evidence you're about to give to this commission the truth?
It is.
And you've prepared a witness statement dated the 12th of June 2024? And just for the record, that's been numbered DOH 0010 0001 0001. Are the contents of that witness statement true and correct?
Yes, they are.
Thank you, Minister. Ms Whetton, will you tell the commissioners your full name? And you hold the position of Deputy Secretary, Mental Health and Wellbeing. And you are also the Chief Officer for Mental Health and Wellbeing under Part 6.2 of the Mental Health and Wellbeing Act. Is the evidence you're about to give to this commission the truth? And you've prepared a witness statement dated the 11th of June 2024?
Yes, I have.
And now that is numbered DOH 0009 001 0001. Now, I understand at paragraph 74, there is a typographical error before I ask you to attest to its truth. At paragraph 74, you say this represents 5% of all clients. I understand you wish to change that to 4%. Is that right? And with that amendment, are the contents of that witness statement true and correct?
Yeah.
Minister, I understand that you've prepared some opening remarks and I'll invite you to read those.
Thank you. And thank you, Commissioners. It's a privilege to be with you here today, and I'd like to provide a short opening statement. I'd like to begin by acknowledging the traditional owners of the land on which we are gathered today, the Wurundjeri people of the Kulin Nation, and pay my respects to elders past and present. I extend that respect to the traditional owners right across the state, including those here and those joining us online. I acknowledge this is and always will be Aboriginal land and that sovereignty has never been ceded. Thank you, Commissioner Hunter, for your warm welcome to country this morning that we had an opportunity to watch online. I acknowledge the commissioners who have led this truth-telling process and all of the First Peoples who have been heard by the Commission. I acknowledge that colonisation has caused historic, intergenerational and ongoing trauma, and I acknowledge the profound impact this has had on the mental health and wellbeing of First Peoples. I acknowledge that there are ongoing injustices within the mainstream mental health and aged care systems, including racism, a lack of cultural safety, insufficient funding and Western models of care which do not reflect a holistic approach
to social and emotional wellbeing, which goes beyond good mental health and extends to connection to land or country, culture, spirituality, ancestry, family, and community. In my relatively short time in the mental health and ageing portfolios, I've reflected on how these injustices are continuing to reinforce barriers to the First Peoples community receiving the care and support they need and deserve. I've seen how ongoing and compounding traumas are triggering to First Peoples, including a spike in emergency department presentations following the outcome of the referendum in 2023. I wholeheartedly and unreservedly apologise for the ongoing injustices in mental health and aged care systems that have caused or contributed to the trauma experienced by First Peoples. Self-determination for First Peoples' social and emotional well-being has not been prioritised enough. Ultimately, First Peoples communities hold the knowledge to determine how to best support the social and emotional well-being of their communities. And while I recognise that the current structural framework of government is a barrier to self-determination, I'm committed to continuing to look for opportunities to hand over power and resources to communities to determine how community can best be supported to be mentally well and age well in a way that is guided by First Peoples' holistic understanding of health and social and emotional well-being. To achieve true self-determination, significant structural change is required. I'm committed to continue working with First Peoples and organisations including VATCHO and the Aboriginal Health and Wellbeing Partnership Forum to continue implementing the recommendations of the Royal Commission into Victoria's mental health system. I would like to respectfully advise that the evidence I give today may contain references to suicide of First Peoples, which I understand can be confronting and distressing. I recognise that the use of suicide data can depersonalise the pain and loss associated with experiences of suicide, which is not my intention. I extend my deepest sympathies to the individuals, families, and communities affected by the loss of loved ones to suicide. Every death by suicide is one too many. Before I finish, I would like to thank the Chief Aboriginal Health Advisor and the Ballot Murrup Unit of the Department of Health. The positive work and change I describe in my statement has been driven by these teams, and I acknowledge the burden and cultural load that is often placed on them. We have a long way to go, but I give you my commitment to work hard to realise change. I will listen, I will be accessible, and I will work hard to enable First Peoples to effect true self-determination. Thank you.
Thank you, Minister. Ms. Whetton, your witness statement also contains a number of important acknowledgements. Could I take you to starting with paragraph 3 and ask you to read paragraphs 3 to 7 and the first sentence of paragraph 8.
I can. Before I do, I would also like to acknowledge that the Wurundjeri Woiwurrung peoples of the Kulin Nation as the traditional owners of the lands we're meeting on today. I pay my respect to elders past and present and to all First Peoples in Victoria and to their ancestors. I acknowledge that First Peoples sovereignty was never ceded. So to my statement, I acknowledge the colonisation and dispossession of First Peoples lands have caused deep and continuing trauma and harm. The mainstream mental health care system in Victoria is based on colonial structures and Western models of care that do not embrace First Peoples' holistic approach to social and emotional wellbeing. As a result, the system has perpetuated harm against First Peoples in far too many cases. This is not just historical. I acknowledge that the Western system to this day does not appreciate First Peoples' ways of knowing, being, and doing. This includes not understanding the First Peoples model of social and emotional wellbeing, which is grounded in connection to country, culture, and kinship and ancestry. While there have been some recent improvements, I accept that the mental health system remains too focused on crisis-driven services and not enough is being done to support First Peoples' self-determination. This includes a lack of funding for Aboriginal community-controlled organisations for prevention, but it's broader than that. I accept that the department is only beginning to come to terms with how far it needs to go to hand over true power and control for First Peoples when it comes to the social and emotional wellbeing for individuals, families, and communities. I also acknowledge the significant experiences of racism within the health sector and broadly in community contribute to First Peoples in Victoria experiencing a disproportionately higher level of distress. This has an impact on their contact and engagement with the mainstream mental health care system, which can lead to poorer social and emotional wellbeing. I acknowledge the disproportionate and devastating incidents of suicide in First Peoples communities. I acknowledge that the effects of colonisation and dispossession, along with the failure of the mental health system to support First Peoples' social and emotional wellbeing, has contributed to this. I acknowledge that each death by suicide re-traumatises community. The failings of the mental health care system were examined by the Royal Commission into Victoria's mental health system. The Royal Commission found that Victoria's mental health system has failed to meet the needs of First Peoples. The mental health system was found to have failed to genuinely recognise or reckon with this exclusion of First Peoples and the ways in which it has contributed to or exacerbated mental illness. These failings are unacceptable and must be addressed.
Thank you, Ms. Whetton. Minister, Ms. Whetton has just acknowledged it in some of the evidence that she has read from her witness statement at paragraph 4, that the department is only beginning to come to terms with how far it needs to go to hand over true power. And you also, in your witness statement at paragraph 41, very candidly state that the Victorian government is only beginning to appreciate the fundamental and significant change required to realise true self-determination. Is that an accurate reflection of where you at least are at the moment?
Yes, it is.
Realising that you've embarked on a project that was perhaps, well, you're only really discovering now what it really involves.
Yes, I think that the Royal Commission findings really did lay out very clearly what deficiencies existed in the system. You know, in order to deal with that in a honest and frank way, we have to look at the way in which we make decisions within government and within departments. So yes, I think I would acknowledge that we have a significant amount of work to do.
This morning, Professor Wallace acknowledged that the mental health system is broken. Do you accept the professor's diagnosis of the mental health system?
Yes, unfortunately, the Royal Commission report again, I think, confirmed that the system needs significant reform and that it is at least a 10-year reform journey to make the fundamental changes that are necessary. And in particular, of course, the findings around the disproportionate impacts on First Nations people are significant.
In your witness statement at paragraphs 19 and 21, you accept that Victoria's mental health system does not accord with First Peoples' holistic concept of health and social and emotional wellbeing. Do you agree that the current mental health system and the government's system of commissioning does not capture First Peoples' concept of social and emotional wellbeing and doesn't currently allow for self-determination in developing models of care?
I think that historically the system has been focused on clinical support and, you know, there's a challenge there for systemic reform to ensure that living experience are embedded in our models of care. I absolutely accept that models of care do not adequately address the social and emotional wellbeing needs of First Nations people. And I'm keen to continue to listen and work with our ATCHOs and VATCHO and other organisations who are, I believe, best placed to lead this important work.
The intention was that Bartlett Murrup, which was the Aboriginal social and emotional wellbeing framework,
Mhm.
was intended to embed First Peoples self-determination. In your witness statement, you reflect on the funding that was allocated to Bartlett Murrup, and you acknowledge that from the outset, Bartlett Murrup was insufficiently funded.
Yes, I do acknowledge that.
Even though you make that acknowledgement, it does remain the government's primary framework to embed self-determination. And the question for you is, how can it achieve that goal if you accept that it was insufficiently funded from the outset?
I think that the framework, there were a number of important projects that flowed from that framework, the demonstration projects, but I acknowledge that it was not ever properly resourced from the outset to be able to realise the goals that were set within that framework. I am absolutely committed to working closely with the Aboriginal Health and Wellbeing Partnership Forum, which now has carriage of the framework, and there are a number of there's an important agreement, a joint agreement between the department, the government and the forum. And I'm absolutely committed to ensuring that I am supporting the work of the Partnership Forum. And I will be keen to see how we can move towards and achieve proper self-determination through that process, including adequate funding for some of the initiatives that are going to be required.
Can I just go to that, the Bartlett Murrup, because I think, I'm not sure where it is, but somewhere in your statement you make that monitoring and evaluation hasn't happened and that it was never funded to happen. So there really is, even though we're coming to the end of what is nearly a 10-year strategy, there's no way of, well, there is a way because we can see the lack of outcomes on the ground, but the strategy itself, despite all the fanfare with which it was launched, has never been evaluated or monitored or anything else. Leaving aside that, the Bartlett Murrup is nearly finished. What is going to happen next, and how can this commission be assured that we don't just get Bartlett Murrup Part 2, which is full of lofty ambitions, but with no actual follow through or evaluation or holding anybody accountable for the fact that platitudes are offered instead of action?
I would not disagree with anything you have said. I think that I'm sure there have been a number of good intentions that have not been acted on or followed through with the vigour and accountability necessary. I have had the opportunity in the short time that I've been in the portfolio to meet with the Aboriginal Health and Wellbeing Partnership Forum members, and I have given them a commitment directly that I will engage closely with them. I'm keen to make sure that it's actions, that we see actions flow. I'm sure that turning up to a meeting every now and again is inadequate, and I'm committed, and I will work hard to ensure that we see concrete actions through that forum and through the agreement that we have with a number of important action items that we've committed to as a government.
Because look, I have to admire those First Peoples who turn up at meeting after meeting, despite no actions actually coming out of it, in the desperate hope that somehow something will happen sooner or later. I'd like their work to be rewarded.
I share that view.
Minister, I'll just step back and finish the issue of funding before we move on. In the 2021-22 state budget, $3.8 billion was allocated to start rebuilding the mental health system following the Royal Commission.
Yes.
And a further $1.3 billion was allocated in the 22-23 state budget.
Yes.
That's a total of $5.1 billion allocated to the mental health system. In terms of funding specifically for First Peoples' social and emotional wellbeing, $166 million was allocated in the 21-22 budget over 4 years to implement the Royal Commission recommendations. Is that right?
116 actually, 116 million.
Thank you. It's a typo in my notes. Thank you, Minister. 116 million. Is that funding part of the overall $5.1 billion investment to the entire scheme?
Yes, that's right.
So whilst 116 million appears to be a large sum of money, it is not in comparison with the $5.1 billion going towards overall system reform, is it?
No.
And importantly, you accept that the currently allocated funding or has not been sufficient to deliver substantive change in mental health responses and outcomes for First Peoples, has it?
No, it hasn't. And I detail that in my statement.
From 25 to 26, recurrent funding of $32.3 million will be provided for First Peoples' social and emotional wellbeing. Is that right?
Yes, that's correct.
And from that recurrent funding, $21.559 million will be made available to ACCHOs and ACCOs for up to 25 social and emotional wellbeing teams.
Yes, that's right. With a rollout plan for a statewide coverage of that program by 2025.
So that works out to about $850,000 per ACCHO per year for social and emotional wellbeing.
I don't have those figures in front of me in terms of each individual ACCHO and ACCO's funding envelope.
So it may be that it's not divided by 25.
No, that's right. Because some ACCHOs are, as I understand it, ahead in terms of their work and their recruitment of staff for those social emotional wellbeing teams. They might be a little bit further ahead than other ACCHOs and ACCOs.
So in terms of those ACCOs, including ACCHOs, and I should say that is the acronym stands for Aboriginal Community Controlled Organisation or Aboriginal Community Controlled Health Organisation. Yes. Just for viewers, in terms of the traditional means of funding those organisations has historically been by short-term project-specific funding agreements. Is that right?
Yes, that's right.
And you've accepted that historical funding model imposes a significant administrative burden on ACCOs because it requires them to make frequent applications for funding and imposes a substantial reporting burden on them, doesn't it?
Correct.
The Productivity Commission recommended a transition to 7-year funding agreements. Are you aware of that?
Yes, I am.
The Department of Health is working on an outcomes-based funding model, but that will not involve 7-year funding agreements, will it?
The project will involve moving to 4-year recurrent funding arrangements, as I understand it. And the second part of that project will look at streamlining reporting requirements. I think there is a strong acknowledgement that the reporting burden is significant under the current model and that we need to move to a much more streamlined system so that we can enable ACCHOs and ACCOs to concentrate on the work that they want to deliver to their communities.
And that the work on reducing the reporting requirements was due to commence on the 1st of July this year?
That's right.
And can you confirm when that reduced reporting requirement will commence?
As I understand it, it will commence next financial year.
Yep.
So it will be 1 July.
That's right.
Perhaps just to add, the moving to the 4-year funding agreements commenced on 1 July 2023, so for the current financial year, and the moving to the streamline reporting is commencing 1 July 2024.
So in about 2 weeks.
Correct.
Commissioners, I'm moving on from funding. If anyone had any questions on those budget specific issues.
I'm just wondering, did the ballot, more that's still current?
The framework?
Yeah.
Yes, it is. Yes.
Is there any funding going into that
Currently,
currently?
it's been taken up through the partnership agreement, is my understanding.
Yes, so some of the key projects that were funded out of Ballot MARP, so the demonstration sites that were about working in partnership between ACCHOs and mainstream mental health services to improve outcomes for people with moderate to severe mental illness, and those 4 demonstration projects have now rolled into what were the social and emotional wellbeing teams that were funded recurrently through the Royal Commission implementation. There's also the mental health traineeship program that was funded under Ballot MARP and is also continuing to be funded now.
Are they're continuing those? So that's the only 2 lots of funding.
There were 10 clinical and therapeutic mental health positions that were funded through Ballot MARP that also now are forming part of those SUB teams in the Royal Commission.
And we haven't mentioned it yet, but I just wanted to check, Kurunga and Ballot Jack is also being funded?
I'm advised that the work as associated with that framework has also now been incorporated into the action plan through the partnership forum.
So Kurunga and Ballot Jack's been put into the partnership forum as well?
Yes.
So the actions that the Department of Health is responsible for have now become a part of the Aboriginal Health and Wellbeing Partnership Agreement and Action Plan.
And so that's a partnership with Aboriginal organisations, I'm assuming?
Yes, with the partnership forum.
Okay, so in the partnership forum, and probably stealing this from Commissioner Lovett there, what authority does that have, that partnership forum?
It works on a consensus model, and there has been work on particular action items from the agreement that has been struck, and funding has flowed for a number of those projects, but there is still more funding that would be required to move to some of the other action items in that partnership agreement.
And sorry, Council, but just on Kurunga and Ballot Jack, I just noticed that it's every 3 years it's supposed to be evaluated. Has that happened?
I'm not aware of that. I think the Department of Families, Fairness and Housing might take the lead on Kurunga and Ballot Jack, so it's not something I'm aware of, but could provide some information out of
Yeah, I just want to know where it sits, who has the funding, who's the lead, and I guess has it been evaluated would be really good, because it does say in there that every 3 years it will. And if we've got a 10-year plan, we need to evaluate to make sure it's working. And if it's not, then we need to adjust it.
Could I just add one detail around Ballot MARP and just about that, the evaluation question for that one is that for the things that were rolled out, that we will be undertaking an evaluation of Ballot MARP as well as where the Royal Commission Aboriginal social and emotional wellbeing recommendations are up to in 25-26. So it's just to give the Commission a sense that for the work that has been done and for the impact so far that we will be undertaking an overarching evaluation.
I think for being 10-year plans, if we don't assess them and evaluate them as we go, and we're just putting money into them or not, then we don't know what's working. And mental health is crucial for our people, as you said in your opening statement. But unless we're evaluating it and we're looking at where those dollars are going, and if it's working, if we're putting them in the right, we're just going along blindly, particularly with 10-year plans, and things change in those.
Given we've focused a bit on Ballot MARP, I might just ask my the remaining question I had about that now rather than going back later. Ballot Murray contained immediate actions for the next 4 years of Ballot Murray, which was in fact up until 2021. Can you tell the Commission whether all of those, what were at the time, immediate action items were implemented?
Yep, Ms. Whetton will take that one.
I can speak to that. Ballot Murray, the framework, it included 28 immediate actions to be undertaken over the first 4 years. And as the Minister said earlier, that a number of the actions were not resourced to commence. I think it's approximately half of those immediate actions were funded to be delivered, and they're either completed or partway through.
And of the other half, has there been a decision not to proceed with them, or are they just awaiting funding? Where are they?
A number of the objectives and intentions in Ballot Murray have then been brought to life through the Royal Commission implementation. So there are a number of actions that will now be being picked up as part of the Royal Commission implementation.
If they weren't brought up in a Royal Commission, would they, and they're in Ballot Murray, would they have ever come to light?
Well, I would hope that if they are identified as a priority by the Aboriginal Health and Wellbeing Partnership Forum, which I understand a number of them have been, that they would still have a high priority for action.
And does that forum come out of Ballot Murray, the people who were part of consulting on that?
That reference group wrapped up after the framework was delivered, as I understand it, the Ballot Murray framework. The partnership forum is now chaired, it's co-chaired by the Minister for Health with the chairperson of VATCHO, and then it has all of the ATCHOs, some mainstream health services and the Department of Health on it.
And so when did that come into play? Because if we're looking at, that's 2017, and then when did that group of people come together that you co-chair?
2020.
There's a gap between Ballot Murray and then having a group that has consensus about how we move forward, and there was no funding. So how, for me, that is set up to fail. If you've got this 3-year gap between having a reference group, got no money, no one's implementing it, and then 3 years later you have a group. And I must ask, what do you mean by consensus?
Agreement is reached at that forum on both the agreement and the action items and the prioritisation of those action items. And I absolutely acknowledge that does not reflect self-determination, that model.
No, not at all. You've got this 3-year gap and no money coming in. And is that consensus between the government and the Aboriginal orgs at the table, or the Aboriginal orgs at the table?
I think it would be collectively across the representation of the forum.
If that means consensus isn't agreed, what happens?
That's an excellent question, and I think it goes to the need for structural change, as I mentioned in my opening statement, to have the ability for proper self-determination for what the priorities are for First Nations people in social and emotional wellbeing.
I give that you're fairly new to portfolio, but I also think there's this gap between Ballot Murray, then you've got Kurunga and Ballot Jack, and you've got, again, frameworks that there's no money going into. They're not happening until a Royal Commission comes into play and we've gone, oh, now it's an issue. I just feel that it shouldn't take, the mental health of our people and a Royal Commission to address that. It should be more important than having a Royal Commission tell you that it's important. We've got the stats.
I don't disagree with you, Commissioner. I think it's important also that the Royal Commission recommendations, there is a role for the Partnership Forum to have an ongoing role in assessing implementation of each of the Royal Commission recommendations, that not only the ones that pertain to First Nations people, but more broadly. So that is certainly an important area of responsibility for the Partnership Forum as well.
Did the Partnership Forum happen out of the Royal Commission as well?
No, it
that was-
didn't. No, it
And
didn't.
so between 2017 and 2020, someone decided we needed a Partnership Forum?
It precedes my time in the portfolio. Perhaps Ms. Whetton might have a bit more of the background on that.
I'm just trying to understand a gap between 2017 and 2020, and then you have a Royal Commission that tells you to do all this stuff, so you do it. And meanwhile, and I don't know the rates of suicide, but I'm sure they're pretty high, and we went through COVID in that time as well.
Yes.
No. I'm just lost for words.
I have one more question just in relation to, for Ms. Whetton, in relation to ballot before we move on. It also, so it had those first immediate actions for the first 4 years, and then it also had aspirations for 10 years' time, which would be until 2027. How is Victoria tracking in terms of achieving those 10-year aspirations?
The 10-year aspirations, they have not been tracked. As we mentioned earlier, that the monitoring and evaluation was not resourced. So we haven't been tracking along the way. There have been evaluations of particular elements, but as I mentioned earlier, that in 25-26, the overall framework will be subject to an overarching evaluation alongside the Royal Commission recommendations.
Ms. Whetton, would you agree that putting in a framework without funding evaluation and monitoring suggests that you're not serious about the outcomes? It's more about the optics and the realities?
I agree it's unacceptable not to fund monitoring and evaluation when you set up frameworks like this. I do agree.
We've seen it again and again and again with Aboriginal frameworks, like literally 30, 40, 50, 60 of these things, none of which have been reviewed. And it's as if we pretend we're doing something when we're not doing anything. We're just trying to kick the can down the road, or even worse, maintain the status quo.
One of the aspects of the Royal Commission implementation is that when we seek and have sought funding for the particular initiatives coming out of the Royal Commission, that we build evaluation into all of our funding proposals so that there is that. And
I think, as Commissioner Hunter pointed out, that the other thing said in there, it would be reviewed every 3 years. So many of these frameworks actually have evaluation monitoring built into them with all sorts of strong statements about what's going to happen, and then it doesn't happen. So how would you build something in where First Peoples could be confident that what you said was going to happen, the evaluation and the accountability, would actually be delivered?
I think from my perspective, Commissioner, it comes down to prioritising the work and prioritising the funding so that work happens. And, you know, that's certainly something that I'm keen to lean in on.
Perhaps, and and it's been suggested by many First People submissions, that there needs to be an independent accountability model that holds the state to account for the commitments that are made, and that the evaluation and measurement is run by this body, so that it isn't the state saying it will do something and they're not doing something, or marking its own homework.
I would accept that proposition.
Ms. Whetton, I've got some questions for you about the closing the gap targets. In particular, firstly, closing the gap outcome 14, Aboriginal and Torres Strait Islander people enjoy high levels of social and emotional wellbeing. That's the outcome that's sought. And also the related target 14, significant and sustained reduction in suicide. of Aboriginal and Torres Strait Islander people towards zero.
Council, can I just check, are you following a document there with that reference or not?
Yes. Yes, yes, I am. I should be, although we have jumped around a little bit. How is closing the gap outcome 14 and target 14 measured in Victoria?
So before I do speak to this, just that I will be talking about suicide and just acknowledging sensitive area and devastating for families and communities affected. The target for outcome 14 in closing the gap is, as you say, it's a rate of suicide by First Peoples population. And in Victoria at this stage, that target is not reported against. And there are a small number of jurisdictions, including Victoria, that's not reported. And it relates to the Australian Bureau of Statistics owns the data source for calculating that rate. And the ABS believes that Victoria's data is not reliable because of the number of First Peoples who participate in the census, and then that Victoria has, in the ABS's view, a small population. Now, I say this recognising it's deeply offensive to First Peoples, and I do say that in the statement as well, but just to explain that this is how the ABS currently calculates it. So it's not currently reported.
And what is being done to enable Victoria to report against the target?
So we are seeking to resolve this with the ABS. We have been, so when I say we, the Department of Health, we've been raising this with the ABS for quite some time to understand their methodology and how that can be changed. We're also seeking the help of the Australian Institute of Health and Welfare to see if they can join with us to undertake some work as well to try and find a way to solve this problem of not reporting. And we're also raising, there are a number of officials, committees around data that we're using some of those committees as well to raise the under enumeration of First Peoples in the census, just that this is a national issue as well. I will mention as well is that we are not wanting to wait for the work that the ABS will do and that we're seeking that they will do. The Coroner's Court of Victoria has reliable, very reliable, accurate data around suicide in Victoria. And we've been looking as a department about whether we might be able to look at our local data and perhaps some data linkage work to understand that rate for Victoria. If we were to do that as part of closing the gap, we would need to seek the agreement of the Productivity Commission, but it's something that we're just in the initial stages of considering. So it's not acceptable to not have a way of measuring it.
And that might answer my next question, which was why can't the state of Victoria rely on the very reliable figures produced by the Coroner's Court to report on that target?
It's a good question. As I understand it, and colleagues in the Department of Health who are working on this, that the methodologies that are used by the ABS across the country for closing the gap is different to the way we collect, well, the Coroner's Court collects that data in Victoria. So it comes down to a methodology question, which again, just want to acknowledge how offensive that is.
But we have the GAR. We have the GAR here in Victoria, the Victorian Government Aboriginal Affairs Framework, which is also aligned to closing the gap. So what are you doing to publicly report through that mechanism?
I don't believe we'd be reporting a rate through that because it's not, but I can take that on notice to see what it is that we do there.
I mean, we have our own implementation plan, as you'd be aware of. Yeah.
Just turning to those, the very reliable information that the Coroner's Court provides, you've the state has provided the 2018 to 2023 statistics to us, and that is BAL 7 0004 0006 0001. And in those statistics, we're told that in 2018, there were 10 suicides of Aboriginal and Torres Strait Islander men, and this rose to 22 in the year 2023. And in that same period, there were 4 suicides of Aboriginal and Torres Strait Islander women in 2018 and 6 in 2023. So the numbers are increasing.
They are.
And it's also fair to say the numbers, there is consistently a differential between the rates for First Peoples men and the rates for First Peoples women in those suicide rates, isn't there?
Yes, yes, there are.
And does the department acknowledge and accept that there are particular specific issues in relation to men's business that need to be addressed to genuinely address those rates?
Can you just articulate some of the things, what investment's been made to work with men on this stuff?
Commissioner, there's a number of important pieces of work. Obviously, increasing the resources for the ACCHO's social and emotional wellbeing teams, noting that those teams understand community best and have built those models of care that are about early intervention. I think early intervention is certainly an area that needs much more focus and resourcing because for too many people, care and support is not sought early enough, and so people are getting into an acute situation before they present for help. We've also been doing some important work through the Ballot Dern Centre and through VATCHO to lead to lead the design of a First Peoples-led approach to preventing suicide and response to suicide risk. So that's very important work, which I'm very keen to make sure that we're supporting the resourcing of. And we've also been working on a broader statewide suicide strategy arising from the work and the recommendations of the Royal Commission. And again, VATCHO are doing the work and leading the work on what that strategy needs to encompass to address First Nations particular priorities.
Thank you.
Looking at those overall numbers, what we can see from the Coroner's Court statistics is that for those years, 2018 to 2023, in Victoria, First Peoples died by suicide at a rate nearly 3 times higher than non-Indigenous people, didn't they?
Yes.
And Minister, accepting that far too many, disproportionately many, accepting that any rate is unacceptable, but disproportionate number die by suicide each year, with that rate increasing rather than decreasing. What is the government doing to stop that?
As I just outlined to Commissioner Lovell, we have got a number of important programs that we are supporting and resourcing. Obviously, those numbers are completely devastating and completely unacceptable, and we need to work much harder in terms of addressing the issues that are driving these numbers. And I'm keen to learn more directly from ACCHOs about, and from also the Ballot Dern Centre and VATCHO about what other supports are needed. I have heard the message loud and clear already from a number of ACCHOs that I've been able to speak with about the importance of early intervention and the importance of having a holistic approach to addressing social and emotional well-being, but also acknowledging that there are other factors that might feed into social and emotional well-being of First Nations people. I think I mentioned in my opening statement that for example, we did see an increase in emergency department presentations immediately following the referendum result. So there are obviously issues that are causal issues society-wide. So of course, addressing those is critically important in driving turning this situation around for First Nations people in Victoria.
A lot of those key drivers are within your portfolio, to the extent that the Coroner's Court statistics show that 81.7% of those deceased had a diagnosed history of mental health. You accept that?
Yes.
And 10.6% had a suspected but not diagnosed history. So that's a total of 90%.
Yes.
And so you accept that mental health is, at the very least, almost in the Venn diagram, a complete coverage for almost all of those people who die by suicide.
Yes, I do accept that.
In your witness statement, you talk about the Suicide Prevention and Response Office funding Living Works Australia to design and deliver a pilot program of community gatekeeper training.
Yes.
And you mentioned that Monash University has evaluated that program and provided a report in March 2024. You say at paragraph 92 of your witness statement that the loss caused by suicide in First Peoples communities is acute.
Yes.
Now, the government has had the evaluation of that pilot program for 2 months. What has been done to get going on a permanent, non-pilot First Peoples suicide prevention program?
In relation to that particular report, this is related to the work of the Ballot Dern Centre and VATSHO, and it will inform future action in terms of implementing recommendation 27.1C of the Royal Commission's report. So that is work that is obviously critically important and that we're committed to ensuring continues.
So the Living Works designed and delivered a pilot for community gatekeeper training. It was evaluated by this office. Is the intention that the pilot that was being conducted by Living Works be continued as part of a permanently funded?
Yes, it's one of the action items out of the Partnership Forum agreement, and my understanding is that that is agreed at the forum, that will be a future action that is undertaken.
I just wanted to go back to your, excuse me, Council, the previous question, the Monash University evaluation of the pilot program. I didn't get the answer to that, to what that's now been delivered. So what was the evaluation? What did it say?
So the evaluation showed that that the training had had some impact, and that, recalling from the report, that that training had supported community members to be able to be the gatekeeper, as I say it, to be a person who's safe in the community, to talk, to wrap a local safety network around someone who might be thinking about suicide, and that training had, I think the Monash report talks about, that training had been retained as, you know, for people to use into the future. Could I add from the earlier question that we would be proposing that from that pilot, we recognise that pilots are just but one thing, and that the Royal Commission said you need to deliver this training, but because it's something that we hadn't done before, that we ran the pilot, and we would be proposing as part of the next budget process that we'd be seeking funding to be able to roll that out more generally.
But to be clear, the pilot's now completed.
The
It's
pilot
finished,
is now completed,
but there's nothing happening at the moment.
not at the moment.
Just moving specifically to budgetary issues in relation to this area, how much funding has been allocated in the 24-25 state budget to suicide prevention and response that's specifically for Aboriginal and Torres Strait Islander people?
It's there are a number of programs that were funded in the 24-25 state budget and $3.5 million was allocated for suicide prevention programs, including the Strong Brother, Strong Sister program that operates in the Barwon region for young people, and also the Yarning Safe and Strong 24/7 helpline.
Thank you, Minister.
That's just two programs. Like one's in the Barwon region. It's not much.
No, that's right. It's two specific programs that were funded in this year's budget, but there is some programs that are funded through the forward estimates from previous budgets that do go to suicide prevention work, and that includes obviously the resourcing of the social and emotional wellbeing teams within ACCHOs, although I acknowledge that more work needs to be done in that area and more resources applied. But there's also the work that I mentioned earlier around the suicide prevention strategy and a number of programs that flow from the Royal Commission's recommendations that continue to be a strong focus.
Just on those social emotional wellbeing teams, did you say there was 4?
No, there's 25.
Okay.
And we're scaling up to have statewide coverage by 2025.
I also wanted to ask you some questions in relation to the Aboriginal healing centres that were recommended by VACCHO. I think they sought the establishment of 5 statewide healing centres, and the Royal Commission recommended that 2 statewide healing centres be established by 2026.
Mm-hmm.
Ms. Whetton, I think I'll leave this question to whichever of you has the answer. In total, $1.2 million has been allocated to VACCHO to undertake the co-design process for those healing centres. Is that right?
Yes, that's right.
In terms of the proposed locations for the healing centres, the plan was that suitable locations were expected to be selected by the end of May this year. Have those now been selected? And if not, when do you anticipate they will be selected by?
They haven't been selected yet, but from my perspective, it's important that those locations are led by First Nations, and so the work on locations and the budget bid that will facilitate the capital program, and whether they are existing facilities or whether there are new facilities and new infrastructure required, all of that work is being led by VACCHO and the Ballot Dern Centre. And they are leading the budget bid process for that work, both in terms of capital, but also the operational funding ask for the 2 healing centres. And that budget bid will be brought forward at the next budget, which will be 25-26. And that will have my very strong support as Minister.
And so it's right to say that no funding has yet been allocated beyond June 2024 for those centres, has it?
That's right.
the Bartlett Dern Centre and the department will develop a business case for the 25-26 state budget process. Is that right?
That's right, yes.
In light of this, is the timeline of 2026 for establishing those 2 healing centres still achievable?
Yes, I believe that it is, yeah.
Just moving now to some of the specific recommendations made by the Royal Commission. In particular, in relation to responses to mental health crises.
Yes.
And with particular focus on recommendation 8, responding to mental health crises, recommendation 9, developing safe spaces and crisis respite facilities, and recommendation 10, supporting responses from emergency services to mental health crises. Ms. Whetton, your witness statement outlines reforms undertaken to date to implement these recommendations. The full implementation of recommendation 10 will occur through what you describe as a phased transition in future years. How many years does the department think it will take to fully implement recommendation 10?
We're not able to put a time frame on that just at the moment. The recommendations 8, 9 and 10, when taken together, there's significant complexity around them. I would say, though, just in talking about these recommendations, acknowledging the disproportionate impact on First Peoples in mental health crisis, because it means at the moment that First Peoples are often coming into contact with emergency responders, some of whom are Victoria Police. It can also include paramedics as well under the current model. And so we're undertaking the work in phases because it's about trying to build the capacity of the mental health system while at the same time preparing, in effect, the paramedic workforce to be able to step in to take on that role into the future.
And Minister, in terms of funding allocated to implement those recommendations,
Yes.
there was funding allocated in the previous 3 budgets for recommendations 10 and 8.3C, which is in relation to the emergency department treatment in each region.
Yes.
The 24-25 state budget allocated 1.4 million over 2 years, 700,000 a year, to continue the teleprompt program to provide paramedics with continued access to mental health expertise while reformed models of clinical assistance are developed. Is that all of the funding allocated in the 24-25 state budget to the implementation of recommendations 8, 9 and 10?
It is, but what I would say is that the funding for the planning and design activities that was provided in the 23-24 budget are still being actioned, so that work continues. I think originally the Royal Commission provided a timeline of having these reforms in place by 2024. It's absolutely clear that we will not be meeting that timeline. And I think we are mindful and acknowledge the fact that the health system and emergency services more broadly have been under significant pressure coming out of the pandemic. And we want to make sure that the changes to the way mental health crises are handled are done in a way that is safe and appropriate. So it will take a bit longer, but that design work is continuing, and there is a lot of work going on across agencies and departments to progress this work.
Ms. Whetton, in your witness statement, you say that additional funding will be required in successive future budgets to enable full implementation of these recommendations. Does the department have any idea of how much funding is required?
Not at this stage. So the budget so far, as the Minister has mentioned, the funding that goes into the planning and design activities, that will help us. And when I say us, it's Department of Health, but working with our colleagues across Ambulance Victoria, Department of Justice and Community Safety, 000 Victoria. So there's a number, and that's just the government agencies, recognising we also need to work with First Peoples and other organisations in this. Those activities will help us determine an estimate for the full implementation.
Minister, you touched that there was some evidence earlier and also in your witness statements in which you accept that many First Peoples fear and distrust emergency services and in particular the police.
Yes.
At present, emergency services are still involved in responding to mental health crises.
Yes.
Ms. Whetton, do you know what specialist training emergency services, in particular Victoria Police, receive in mental health crisis response?
I'm aware that they do undertake mental health related training, but because it just sits outside, Victoria Police would be better able to answer that. But I am aware that they do undertake some training.
Minister, given your acceptance that there is a level of fear and distrust of emergency services amongst First Peoples, do you consider it's appropriate for police to be used as the state's response when First Peoples are having a mental health crisis?
Clearly not, and clearly the Royal Commission recommendations go to the importance of having a health-led response, which is what we are working towards. It will unfortunately take longer than we had hoped, but it's a very important part of the Royal Commission's recommendations, as is earlier intervention, so that First Peoples do not find themselves in a position where they have to present in crisis. So there is a holistic response to this, I think, beyond recommendation 8, 9 and 10. But I do accept that this is not a good situation, but we are progressing the work as quickly as we can, noting the need to have safe systems in place.
And whilst it's not a good system for anyone, because of Victoria's colonial history and the role of police in that history, it's a particularly bad system for First Peoples, isn't it?
Yes, I would agree with that.
Commissioners, I'm going to move on to a new topic now. If there are any further questions in relation to the Royal Commission recommendations.
Well, just to say, look, it's very disappointing that everything is behind time, just beginning maybe in the next budget cycle. It's quite, does not make me feel hopeful.
Yeah, I think that just building on that, I mean, what's going to give us and our people hope that our recommendations that we make to you are going to be taken serious, taken on board, and responded to?
I think that my personal view is that we haven't prioritised these recommendations that impact First Nations people in a disproportionate way enough. I'm certainly committed within my ability to try and make sure that we're prioritising the work and the investment that has to go into delivering on these recommendations. So I will continue to do whatever I can to progress these issues, but I also want to take every opportunity I can to hear directly from our First Nations community health organisations and community-led organisations about what's going to work best.
And I think that's fair enough, and I understand your own personal advocacy, but I think, you know, probably needing more clarity from your colleagues around backing in that aspiration as well. I think because our people have been coming forward for the last 200 years, been saying the same thing. In particular, the last 50 years around education or health or housing. So the advocacy's been there, but the actual, I think we've been heard but not listened to. So yeah, I'm just really concerned about, you know, the work that we do, and the recommendations that will be provided by this commission. They need to be taken seriously, and because they are generated by systematic exclusion, and also First Nations voices.
Minister, do you have any insights into what sort of recent history might explain some of these delayed outcomes? Because it is something that we've heard over and over from one minister, one secretary, deputy secretary after another, and I'm sort of searching for what is it that has blocked the execution of what seemed to be good policies and genuine commitment, but then no delivery. And is there something in recent history? I mean, thinking maybe COVID, I'm thinking of maybe, political changes in leadership. Is there something that explains this phenomenon?
I certainly am of the view that COVID disrupted a lot of government reform and priorities. No question about that. I acknowledge that the Royal Commission into the mental health system's recommendations were very detailed, very complex, and did set out a 10-year reform journey, if you like, because of the complexity of the recommendations and the systems that need to change. So I think that's a factor. But I think that there's absolute commitment to continue to implement every single one of the recommendations. That will not go to all of the issues that need priority. And I'm obviously, will be very keen to see what the Commission recommends in relation to the mental health system and what more can be done to address the unacceptable disadvantage experienced by First Nations people in our mental health system. I think COVID is a big factor in terms of the timelines on some of these recommendations.
Can you just elaborate on that a bit? Because as I say, it's a real puzzle to me. It's a very unusual situation where you have government coming along and saying, here are the policies, they seem to be the right ones. There's a genuine commitment. I think that can be accepted, but then there's this blockage. And how would COVID, how did it impact?
Well, I think from my perspective, I would imagine that, and it was before I was in this particular portfolio, but I know that the Department of Health were completely focused on the pandemic response, sort of 1 in 100 year event with very significant health impacts across the community. So I know that that was, sucking up a lot of resources of the department at the time. But I don't want to provide that as a way of giving an excuse, because there were some aspects of the Royal Commission implementation work that were able to continue on during COVID. Not everything, but many of them were able to be progressed. We just need to redouble our effort and our focus on rolling out those recommendations that are critical for better outcomes across the board.
Chair, would it, it's now 3:14. I wonder if the commissioners wanted to stop for a 10-minute comfort break. We adjourn for 10 minutes.
How long were you suggesting?
If the commissioners would like 10 or 15 minutes, I'm in your hands.
10 minutes. Thank you. All right. So,
Return at 3:25.
yes, 4:30 or 3:30.
Or 3:30. Thank you. Thank you, Chair.
Thank you.
Minister, I'll move on now. In fact, sorry, Ms. Whetton. The questions I was going to address now relate to issues of cultural safety for First Peoples. You say in your witness statement that work has been undertaken within departments and agencies to focus on better understanding the needs and challenges being faced by mental health and emergency services.
Yes.
And you also say that the department will prepare a detailed plan for external engagement over the coming months, including specific consideration of engagement with First Peoples and how to ensure the department's engagement is culturally safe.
Yes, and that was in direct reference to recommendations 8, 9 and 10, I recall.
Does that mean that at the moment there is not a process across the department for ensuring cultural safety for First Peoples?
No, that direct reference was in relation to the work that we're undertaking for recommendations 8, 9 and 10. And I talked earlier in the session around, so far a lot of the work has been undertaken by government agencies, and that we recognise that part of the next stage of the work that we need to engage with First Peoples, particularly given proportionate impact on First Peoples related to emergency responses to mental health crisis. And so, but we try to point out in the statement, or I try to point out in the statement, that we want to make sure that any engagement we have for that work, that it's culturally safe, recognising that that can be a challenge.
And what work has been undertaken to date, and what work remains to be done in order to ensure the department's engagement with First Peoples is culturally safe?
You mean generally?
Yes.
Yeah.
Yep.
So I acknowledge that we've got a fair way to go in this, and that it's something that I think we say in earlier statements. It's one of the areas where I think we're really needing to grapple with this. It's something that we haven't done particularly well in the past. We do have an Aboriginal cultural safety framework in the department, and we use that both for the services we fund as a department, but also for our own department as well. That includes an assessment tool where either the service or the department can look at where that particular group is. When I say group, I mean in the department or in the service, where they're up to in terms of cultural safety and what else they need to do to be culturally safe.
And you're aware that the Charter of Human Rights and Responsibilities contains a right, a cultural right that's very specific to First Peoples in section 19?
I'm aware of that.
And you're aware that the cultural rights in section 19 require some consideration of culturally protective factors like social and emotional well-being, that the state is required because of section 19 of the Charter to give consideration to things like social and emotional well-being and other First Peoples culturally protective factors.
Mm-hmm. Yes.
Can I just, on that, you understand section 19 cultural rights?
As in, yes, I'm aware of it.
And so you would also know, working in social and emotional well-being, that they are our protective factors, correct? So are they in all that you do? Would they be in, would you say they're in all the work that you do? Putting the rights of culture first for First Peoples?
I'd say it's something that we are improving on in the department. It's something that we are focused on. One of the things in the Mental Health and Wellbeing Division, which is the division that I lead in the department, we're undertaking work at the moment to develop our own cultural safety plan in the division, because
but it's in the Act. It's in the Charter of the Human Rights of Victorian. So do you just decide whether you uptake that, or like, is it just a decision that you make?
No, I'd say it's about bringing it to the forefront and bringing it to life in every piece of work that we do.
So how long's that been around, that Act?
I believe it's 2006.
And what are we in?
2024.
And so it also applies to the mental health principles. And so the cultural safety principle applies in full conjunction with this right. Can I just say that it states treatment and care is to be appropriate for and consistent with cultural and spiritual beliefs and practices of a person living with a mental illness or psychological distress. And we go down further, regard is to be given to Aboriginal and Torres Strait Islanders people's unique culture and identity, including connections to family, kinship, community, and country and waters. And then it goes on to say treatment and care for Aboriginal and Torres Strait Islander peoples is to the extent that it is practical, appropriate to do so, and be decided and given having regard to the view of elders, traditional healers, and Aboriginal and Torres Strait Islander mental health workers. That's 2022 Act. So how long do we have to wait for these charters, these acts? Who's responsible for these acts and charters we just come up with for cultural rights that actually protect our people and they're not implemented in any way, or it just feels like if you want to put it in there? This is the core of mental health well-being for our people. It's in there in, well, let's say in white law, LAW, for people to follow. It's not there for a reason. So why are these not followed?
Commissioner, can I perhaps acknowledge again, as I do in my statement, that in terms of our mental health services, so our mainstream mental health services, there's been in the statement of priorities that are provided to each of those mental health and overall health services a requirement to provide culturally safe care, but clearly that has not been met and there's no accountability framework.
If you listen to Ray Lovett's witness, when he was a witness, his testimony, he talks about racism and discrimination causing PTSD on a daily basis to our people, which adds to suicide. And then we've got these charters and these policies and these laws and these frameworks, but no one seems to worry if they're implemented or not.
I'd absolutely acknowledge that there hasn't been proper accountability within mental health services, which is why the statement of priorities will in future require mandatory training in cultural safety.
Who's going to monitor that?
Well, there will be a set of requirements on each health service to demonstrate that they are applying the mandatory training and that they are applying the principles.
Can apply it, but who's monitoring that it is actually a culturally safe service?
I think the department has a number of monitoring mechanisms that would be available to them to step in if a particular health service, including a mental health service, was not fulfilling its obligations under those statement of expectations that are provided by the health minister directly to the service. And I think that understand the secretary of the department gave a little bit of evidence about that earlier today in terms of what triggers and what steps could be taken if a health service was not complying with those cultural safety undertakings.
Well, I'm just going to say that this commission will be watching very closely how that does that. And in this day and age, it's just, I'm appalled that just with the mental health system, we know it's broken anyway, but for our people, it's even worse. And we've got in the charter cultural rights, and then you've got the other act, the Mental Health and Wellbeing Act in 2022, which mentions our people again. We're being left behind and we're dying because of it.
And Commissioner, if I can add, I've heard directly from ACCHOs about some of them experiencing great frustration trying to liaise with mental health services in our mainstream system and them feeling that they have not been taken seriously enough in terms of individual community members' social and emotional wellbeing needs. So this is something that I'm absolutely committed to working with our ATCHOs and ACOs on what more can be done to make sure that those models of care are appropriate. And that
Do you fund those services they work with?
yes.
Yes. So who can say so they're obviously not culturally safe. So where does this authority lie that people either, I don't know, I'll use the word be reprimanded for being culturally unsafe and racist?
I think it's an unacceptable situation, and I see the statistics of First Peoples reporting unacceptable levels of racism that they've experienced in the system, and we need to make sure that we have more accountability in place, including through funding arrangements of those mental health services.
I'm going to say a lot more accountability, and I will add, while we're talking about statistics, each is a number is a person.
Absolutely.
Yeah, and I just want to remind people of that. So while we're not upholding cultural rights and the system is racist and discriminatory, that adds to the suicide rates of our people and going untreated mental health issues. And so it's just not, I'm just frustrated sitting here. But Ballot Murray, Kurunka and Ballot Jack, we've got cultural rights, we've got all this stuff. Like, we've got it all in writing, and it just fails to be implemented correctly for our people again and again. And then we want to go, and where do we end up? The coroner's court. It's not good enough for our people. It's just not.
You, Commissioner.
I think we heard earlier, just building on that really, and we heard earlier, which hence the sentiment being expressed by the Commissioner here, that the Deputy Secretary from Hospitals and Health Services, one of her main responsibilities is organisational performance. Now, when it comes to cultural safety and racism linked to funding outcomes, threshold or the bar was incredibly low when it came to our people's rights and interests. So I think that's where, the strategic hooks are there, but they haven't been followed. And then again, there's no independent oversight, there's no accountability on the system. Our people are the ones that miss out.
I accept that that's the case.
Ms. Whetton, in your witness statement, you note there's a commitment under the Aboriginal Health and Wellbeing Action Plan to mandate cultural safety planning in all public and community health service settings. And you observe that it hasn't been implemented, and in September 2023, the Forum agreed to pause this action in order to progress other actions.
Yes, I understand that to be the case, and this was about health services generally, of which mental health services are part, but it was about health services generally.
And do you know when this pause on implementing this action item might be lifted?
I believe it has been lifted, and that VATCHO is now undertaking work to develop cultural safety standards for health services, and also a cultural safety accreditation program. And that, as I also mentioned in my statement, and the Minister's referred to earlier, for the 2024 statements of priorities, that the cultural safety training will be mandatory. It's previously been a goal, and it hasn't been mandatory and not a requirement, so that I believe that work's now unpaused. Getting back to that.
So currently it's not mandatory for health services to deliver cultural safety training, is it?
As I understand it, it's been a goal that's been included in statements of priorities of previous years, but not mandated, but it will be for the first time in 24-25.
And you spoke about the funding that VATCHO has received in the 24-25 state budget. As I understand it, the total funding sought by VATCHO could not be allocated, and this will limit the breadth of the cultural safety work that VATCHO is able to do, won't it?
I understand that to be the case.
Are you aware of what the shortfall was between the amount that VATCHO sought and the amount it was allocated?
I'm not, it's just a bit outside of the mental health portfolio, so I'm sorry, I'm not aware of that.
Sorry, I have one more question in relation to that training. Your witness statement also mentions that VACCHO has drafted standards, including delivering cultural safety training, and undertaken a feasibility study for a First Peoples-led cultural safety accreditation scheme for health services. What was the outcome of that feasibility study?
Again, I don't have the detail. That just it's a broad Department of Health piece of work, but I can provide some information to the Commission if it would assist.
That would be useful if you could provide further detail about what the program involves and who is delivering it. I've now got some questions about compulsory treatment.
I'll just ask a question, sorry, back to the other one about cultural safety. How many Aboriginal staff do you have in your area? Or in working in the mental health side from the government's perspective?
Yes, so I think
Not names, just because
no, no.
people have come and mentioned names. It's never about names,
No.
it's about how many people.
No, I understand. In the Mental Health and Wellbeing Division, I have, it's called the Ballot Murrup Unit, and I have a number of First Peoples working in that unit as well as a part of the division. I have 9 staff in the division who identify as First Peoples, which again, just talking about numbers and statistics, but it does represent around about 4% of my overall divisional workforce.
And what's the most senior level there?
The most senior person who identifies as First Peoples is a director level, so who leads the Ballot Murrup unit.
Ms. Whetton, an independent panel was appointed in October 2022 to conduct the review of compulsory treatment. And a public consultation process was started in April 2023, and there were 84 responses. And as I understand it, in July 2023, the panel completed its work. Is that right?
In 2023, the panel ceased its work, but had not yet provided a final report.
And what is to be the result of that work?
So the panel, while it was working together, undertook fairly significant work in engaging with many organisations to talk around the compulsory treatment criteria. They undertook an Engage Victoria process, or public process, to seek submissions, undertook a number of pieces, or commissioned, I should say, pieces of research and analysis. So all of those pieces of work that had been undertaken by the panel, it's now sitting with the department to synthesise that work and provide some advice to the minister later this year.
And my curiosity impels me to ask what happened, because the panel was asked to deliver a report, but it didn't. Did they all die, or?
It wasn't planned for the panel to cease work when it did, but there were, say, a number of factors about how the panel was working together that meant that it was disbanded at that time.
How many were on the panel?
5 people.
Were some of those people First Nations people?
No.
Does that mean that nothing is currently being done to progress the recommendation on compulsory treatment, or nothing has been done other than the appointment of that panel?
So the review was one piece of work that had been announced by government. There is, if we're talking more generally around how we reduce compulsory treatment, is that?
Yes.
Yeah.
Yep.
That the Royal Commission called out that compulsory treatment should absolutely be used only as a last resort, and recognise that it is traumatic and harmful, and particularly for First Peoples, that it's particularly triggering. There is a piece of work that Safer Care Victoria is currently leading called it's a Reducing Compulsory Treatment piece of work, and they are have they're just getting started in this piece of work and recommended by the Royal Commission to work with a number of services to look at their local data about what it's telling them, including for First Peoples and non-First Peoples, and then to they'll work through methods and initiatives to reduce that compulsory treatment.
Your witness statement gives a fair amount of data in relation to compulsory treatment.
Sorry, sorry, Council, what page is that on?
In
15.
Thank you. Just jump to the tables.
That's page 15.
At page 15, and I'm thinking in particular of, it starts on 15 and then the bulk of the tables are on pages 16 and 17. And commissioners, you'll see each of the hospitals are listed there, and using the top of the table, we see the first column is percentage of First Peoples clients with at least one compulsory assessment or treatment order, and the second column is non-First Peoples. And it's a percentage, and we can see that for each of those health services, I think it was except St Vincent's Hospital. For everyone except St Vincent's Hospital, the percentage of compulsory treatment orders were higher for First Peoples. And for St Vincent's, the numbers are comparative, but slightly lower for First Peoples. And I think we see similar data on page 19 in relation to restrictive interventions, which continues on to page 20. So the numbers show that a significant number of First Peoples received at least one compulsory treatment over the past 5 years. That's 5% of all clients of area mental health services and 21.3% of all First Peoples clients during that time period.
That's right, and that is the typo that we
that 5% is meant to be 4%. Thank you very much.
Sorry.
I just hadn't picked that up. Minister, since 2014, as Commissioner Hunter mentioned earlier, the legislative framework in Victoria has required, firstly, that principles specific to First Peoples are taken into account, but also that compulsory mental health treatment should only be used as a last resort. So that's in the legislative framework already?
Yes, that's right.
And changes have also added human rights principles and, as I've said, principles specific to First Peoples. But those legislative changes have not reduced the rates of compulsory treatment for First Peoples, have they?
No, the figures remain stubbornly unacceptable.
Why would that be?
It could be a number of issues. It could be that First Nations people are seeking treatment and care later instead of earlier. It could be that there have been low levels of cultural safety within that particular facility. It's difficult to pinpoint exactly, but the statistics remain unacceptably high, and we need to drive those down.
Wouldn't it be your job, so to speak, to find out why that hasn't moved, like to make it safer for our people, or why this is happening?
Yes, it is, and as Ms. Whetton has pointed out, there are a number of important pieces of work that are being driven by Safer Care Victoria to make sure that we are changing that trajectory. This is probably one of the Royal Commission's recommendations that was given a longer time frame to implement change because of the complexity. But I absolutely accept that it is part of my role to make sure that the disproportionate impact on First Nations consumers is addressed.
And the work that
Accept
Safer
that.
Care Victoria are doing, are they doing it with Aboriginal people, or are they just doing it for?
My understanding is that there is work being done to ensure that we are working with First Nations organisations about this work. It would be my very strong expectation that that be the case.
Lots of expectations happening. Like this, just if it doesn't happen, what happens? If they don't,
I've given a very strong indication to my department about what I expect in terms of proper engagement and working with organisations that are best placed to come up with the models that are going to see a reduction in compulsory treatment for First Nations people.
Minister, can you explain to us, because we all have lived experience on this side of the table and our people of, in this regard, we've got really good strategic hooks or opportunities to make sure that our people can, have more safety and access to mental health services and health services, right? But, and it takes a long time to enact that. But then when it comes to changes to bail laws through legislation, changes to the Child, Youth and Families Act around our children, raise the age, these things get enacted straight away and so tightly and really to the point where our people are significantly overrepresented in a detrimental context. But then when we have active policy and legislation that helps our people, we don't see that level of services, Minister. Can you share some response to that?
I think I've acknowledged in my witness statement, in the evidence that I've given today, that not enough priority has been placed on this work, and I want to do whatever I can to change that.
Just looking at those very stubborn numbers, which haven't changed since 2014, despite some very impressive, the inclusion of some very impressive legislative drafting. Is it possible that psychiatrists are continuing to do the same thing, regardless of the new legislative tests and thresholds?
That is possible, although I know that the chief psychiatrist is taking a lead role in terms of making sure that there are practice guidelines in place that go to the need to reduce compulsory treatment orders in the system.
And one of the issues may be you're attempting to educate a cohort of people who no doubt went through university at a time when the idea of cultural safety or First Peoples as a specific cohort needing very specific care and treatment was just not a part of their education.
I wouldn't have thought so, no. And that needs to change, as does the accountability and the expectations that government place on our health services. And I think, it's not going to be one measure that turns this around. It's going to be a range of different efforts and initiatives across the system.
You mentioned in response to something Commissioner Lovett said that, or it might have been Commissioner Hunter, that one of the reasons those numbers remain stubborn is potentially that First Peoples are coming into contact with mental health services very late in the piece.
Yep.
And would it be fair to say that as a result of that, if you are, and that may be because those services are not seen as culturally safe, so it's only when things are actually on fire that First Peoples will go to them?
Yes, I absolutely accept that, because by its very nature, compulsory treatment means that you have not successfully sought voluntary care and support before that point, or you may have, but it has not resolved. So yes, that that would definitely, I think, be one of the issues that need to be addressed. And part of addressing that is providing more resources for early intervention and prevention.
So to the extent that anyone might be under the illusion that this idea of cultural safety is a soft issue,
No, it's not.
directly contributing, no doubt, to compulsory treatment rates. To first people's feeling
Yes.
culturally safe is not unsafe is no doubt contributing to those high.
I would accept that that premise, yes.
And moving to seclusion, seclusion and restraint numbers, I think it's Ms. Whetton's witness statement. You refer to the recommendations of the Royal Commission that the Victorian Government ensure the Chief Medical Officer for Mental Health and Wellbeing, which is you, develop and lead a strategy to reduce the use of seclusion and restraint.
Yes.
And you've mentioned that the department is seeking to have the strategy finalised in 2025. Given we've seen in your witness statement that those traumatic and methods under the legislation continue to be used disproportionately against First Peoples, why is it taking so long for the strategy to be developed and implemented?
The work's been underway on the strategy for, I think, at least 1.5 years, almost 2 years. And the Royal Commission has this strategy as a long-term piece of work that needs to be undertaken. That's not an excuse for the work it's taking now, but we've been undertaking significant engagement, including a public submissions process around this, because so much of it is around being much more transparent around when and why restrictive interventions are used, and also then to change work practices. So working, it's quite a sensitive topic to develop it, so we've wanted to not rush it. I would say too, though, that while we're undertaking the strategy, that we have actually seen the rates of seclusion and restraint come down for all consumers, including for First Peoples, over the past 5 years. So the evidence in my statement does point still to a disproportionate impact, but there have been year-on-year reductions of those events.
So there's numbers kept of restraints, and would you include restraining and confinement in that? So would restraining also include police data?
No, this is only restraint in a mental health service.
Doesn't it apply? Wouldn't it apply to both? Does it apply to both under the Mental Health Act, or police don't come under that, their mental health and wellbeing? Look, I'm just wondering, sorry. I'm just trying to understand it.
This is in health.
Yes, it would be under the
services.
powers in the Mental Health Act that data would be based on.
Yes.
Using the specific
In a
Mental Health Act
service.
powers. Yeah.
But we're just talking about mental health. How do you not apply it? Sorry, is it siloed?
Well, as I understand it, those acute interactions with police when there's a moment of detention wouldn't be using the treatment powers under the legislation.
No, not the definitions of seclusion and restraint.
Okay.
It might be worth pointing out the reduction that we've seen over the last 5 years in the rate of seclusion. So we have seen a reduction of 56% for First Nations people in the use of seclusion, and a 54% reduction for non-Aboriginal people. And of course, we still have a way to go, but I do think that we are on the right trajectory in terms of minimising and ultimately eliminating the use of seclusion in the mental health system.
Ms. Whetton, just going back to the aspects of your witness statement that address this, in particular, the strategy that's being developed. You mention that the work to date has not reflected a broad engagement with First Peoples communities and organisations.
That's right.
And what steps are being taken to rectify that, to ensure that this engagement does occur before the strategy is finalised and implemented?
The work that we have done to date, and as you say, it's not broad engagement. We have undertaken some engagement. We did have a system leadership forum around the strategy that VATCHO was part of, but I think we do have a few more steps, or quite a few more steps in strategy development to go. And so I think we'd be looking at the engagement work we've done to date to be sure that we are working with First Peoples on that strategy.
At the moment, there hasn't been enough, though.
Yes, I accept that.
When's that due to be finished, that work? Is there a date on it, or
there's no date, as I understand it, there's no date provided in the Royal Commission for this particular piece of work. It's something that's talked about over a long period of time, over the 10 years. We are aiming to have that strategy finalised in 2025.
Thank you. Commissioners, I was going to move on to public intoxication reform. Minister, in your statement, you acknowledge that the criminalisation of public drunkenness unacceptably and disproportionately affects First Peoples.
Yes.
In terms of the monitoring and evaluation plan for the statewide model, you state that the Department of Health is currently conducting a process to engage a First Peoples-led evaluator for the health component.
Yes.
And when do you expect that engagement process to be completed?
I think that the estimate for completing that work is 2025. Correct me if I'm wrong.
For the actual evaluation report would be around September 2025, and the process to have someone come on board, we're expecting over the next 1 to 2 months. Just working through that at the moment.
And in terms of engagement with ACHOs in design, scope and implementation of the original trial site program and statewide model, an evaluation report of that program found that the Aboriginal Advisory Group was underutilised and that the public intoxication reforms would have benefited from earlier and more effective engagement of and communication with Aboriginal stakeholders. How will the Victorian government ensure sufficient engagement with Aboriginal stakeholders going forward?
Yes, I absolutely acknowledge that that was a finding of the evaluation of the trial sites and the arrangements that fed into that trial. We have established and just recently appointed Helen Kennedy to chair the independent monitoring and oversight group that will advise the government. It'll be made up of predominantly First Nations representatives. Will continue to advise the government about the statewide model and provide feedback to me as Minister about what aspects of the public intoxication reforms are working well, which might need more attention, and how the service model is operating across the state.
And is Helen Kennedy has extensive experience in relation to social and emotional wellbeing work?
Yes, that's
is that
right.
the same person?
Yes.
Yes, she's.
Just making sure I had the right person in my head. Just on a related topic, alcohol and other drug services. You've acknowledged in your statement that there is a pressing need for specific and culturally safe alcohol and other drug care, given the disproportionate number of First Peoples seeking help from those services. Many of the alcohol and other drug services in Victoria are operated by NGOs And the department does not mandate cultural safety training for those services, does it?
No.
The Aboriginal health and wellbeing, the action plan includes supporting alcohol and other drug services as a priority, including reviewing current care mechanisms to ensure that they're culturally appropriate and safe.
Mm-hmm.
And prioritising intake and assessment processes and ensuring mainstream alcohol and other drug organisations embed a consistent cultural safety practice in their models of care.
Yes, that's correct.
Does this include NGOs as well as government organisations?
It's not a mandated system, but there is a high level of preparedness to engage in this work amongst our NGO providers across alcohol and other drug services. In addition to that, we recently announced a statewide action plan to try to reduce drug harm across the community. And one of the commitments that we have made is that we will develop an AOD strategy across all of our services. And I want to make sure that that process engages directly with those First Nations organisations that are already delivering alcohol and drug services, but also broader than that, to make sure that our mainstream drug and alcohol services take into consideration what they need to do to provide cultural safety. For example, when we are commissioning services, we, as part of the tendering process, require those organisations to demonstrate to us how they will provide culturally safe services. So we want to strengthen that further by making sure that the AOD strategy has this as one of the key priorities.
The other agreed actions in the action plan include undertaking a whole of system First People specific alcohol and other drug service, demand and planning assessment,
Yes.
and designing the service model of a culturally safe, gender specific residential detoxification and rehabilitation facility for First Peoples women.
Yes, that's right.
And that
very
was
important initiative, and something that I will be very keen to drive in terms of both the time frame associated with delivering that service and making sure that it is a service that stood up and that we are working very closely with First Nations organisations and ACOs and ACHOs to develop that service.
That sounds like a very important service.
Very.
Can you give an indicative timeline?
I think that this is a recommendation from a coroner's report. I think the time frame that was given was 2030, but I would hope that we would be able to progress this work much quicker than that, and that would be my desire, to make sure that we are looking at, not waiting that long. There is a significant need right across the state for specialist alcohol and drug services.
And just, I guess my concern is that sort of you might sort of get a little boutique sort of when obviously what is needed is a reasonable size, long-term funded, First Peoples led thing. So what sort of size would you look at for this treatment facility?
Look, I'm not sure if I'm in a position to say how large at this point in time, but it'll obviously be really important to look at what the demand is across not just metropolitan but also regional Victoria, and make some decisions based on, what that evidence is showing us.
Okay. Minister, in terms of funding for alcohol and other drug healing services for First Peoples, as I understand it, 15.27 million was allocated in the 22-23 financial year and is recurrent funding for 33 ACOs and mainstream service providers across the state.
Yes, that's right.
All alcohol and other drug treatment providers are required to report to the department various information in accordance with the Victorian Alcohol and Drug Collection, VADC.
Yes.
Is it the case that VADC requires an organisation to have software systems and staff with particular skills and training in order to report this information?
Yes, that's correct.
And some service providers, including First Peoples-led service providers, may not be able to report VADC in full or in part.
Correct.
Without accurate data collection, is there a risk that insufficient alcohol and other drug services are available to meet the needs of First Peoples?
Well, that's certainly a risk and one that we want to make sure we reduce. And obviously getting good data is a bit of a challenge in a number of different settings, and we've talked about a little bit of that today. But I want to work closely with VATCHO and also with our AOD services who are providing support to First Nations communities about making sure that we address that situation and that we provide support from the department to be able to improve data collection.
So that they can report fully.
Yes, that's right.
Minister, in your statement, you reflect on key opportunities and changes in the mental health system for First Peoples.
Yeah.
Oh, sorry, challenges.
Same.
I think that is what I meant to say. In your view, what is the most urgent priority for the mental health of First Peoples?
I believe that there is an urgent need to prioritise early intervention and models of care that are holistic and delivered as much as possible by our ATCHOs and ACOs who in my short time in the portfolio, I am convinced that they are the best place to know exactly what it is that communities need in order to address social and emotional wellbeing. I obviously am very concerned about the levels of harm that are occurring and the disproportionate impact on First Nations people experiencing acute mental health distress. And I want to work closely with both VATCHO, the Ballot Dern Centre, and the Aboriginal Health and Wellbeing Partnership Forum to continue to drive what First Peoples are telling me are the priorities for addressing that unacceptable trajectory and how we might turn that around. I think another key challenge, but also opportunity for us, is to look at ways that we can scale up First Nations people working across the sector, both in Aboriginal controlled organisations, but more widely. I have heard directly from First Nations people in the sector that we don't want to have a situation where we create positions that might be seen as sort of standalone Koori liaison officer type roles that have got no support, no mentoring, and that we're really not providing the systematic mentorship and building that workforce so that those individuals are not expected to carry an unacceptable load. So I do want to have a close look at our workforce initiatives and priorities to make sure that we're adequately funding additional opportunities for Aboriginal people to work in the mental health system. So there's obviously a lot of demand pressure on the system right now. I want to make sure that that demand pressure does not have adverse impacts on First Nations consumers, whether they're seeking support through an ACO or ACCHO or in the mainstream part of the system. So there are many priorities and many pieces of work and opportunities that I want to get on with and work with First Nations people on. But there's just a few of the key things that I think need a very strong focus urgently.
You also state there's a need for stronger accountability mechanisms.
Definitely. Yes.
To hold services to account when they lack cultural safety in particular.
I would agree with that.
What could these accountability mechanisms involve? There's been some questions earlier. What power does the government have to implement them across all mental health service providers?
I mentioned earlier that we are moving to a mandated system of training for our mental health services, and I welcome that change, and I think it's well overdue. But that is only one aspect, and there's got to be much stronger accountability measures, and I will be working closely with Ms. Whetton and her team and working across the department to make sure that there are proper accountability measures put in place and that it's not just another bureaucratic exercise to be gone through, that there are actual and we measure how those accountability mechanisms are working and whether they are changing the culture within our mainstream mental health services.
Yes, you've received a number of questions from the commissioners today, many of which do relate to accountability.
Yes.
Throughout the various hearings that Yoorrook has held, there have been reflections on many recommendations that have not been implemented. So community is also very interested in how you will be making sure these things actually get done.
Yes, well, I will be very keen to make sure that I'm getting regular updates on how we are performing. But further to that, I think that there needs to be much more accountability directly back to our ACOs and ACCHOs who are at the front line really of the social and emotional wellbeing challenges across the community. And they also need to know that when they interact with our mainstream mental health services, that they're going to be listened to, that their expertise are going to be respected, and that there's going to be proper accountability back to them when they're trying to provide support for individuals that might need additional assistance through a mainstream service.
Commissioners, those were my questions. Were there any other questions?
I have one, and it's in your statement under aged care 223 as your minister.
Yes.
I'm not going to ask you questions in particular about it, but what I want to talk about is that we have two facilities, ACES and Rumballara, which I'm sure you're aware of.
Yeah.
We've heard evidence from both of those, and I'll either call it palliative care or end of life. They actually don't get funding, but each supply a room for that for our people without funding, because they want to make sure our elders go to the dreaming in a way that's respectful. It's not funded. And I know Commonwealth is, but it says here that I'm responsible for advocating on behalf of older Victorians to ensure equity and access to service. So I implore that you go and speak to both those services. And we were there in both those rooms, and the amazing work they do. Our elders deserve better than to have one room that is not funded for.
Thank you, Commissioner Hunter. I've actually been to Rumballara, and I have seen the amazing work that the staff do in that aged care service, and I will absolutely take that issue on and speak to my counterpart in the federal government about the palliative care funding.
Thank you.
Can I ask some questions around what work are you doing, or is your department doing to work with the Department of Education around our children in primary and secondary school around mental health and mental health issues?
I'm happy for Ms. Whetton to supplement, but just from my perspective briefly, I know that the Department of Education has been doing quite a lot of work on mental health supports within our state school system, both secondary, but also plans to roll out a similar program in primary school. As a former early childhood minister, I have seen firsthand some of the amazing work that's going on in our Aboriginal early childhood services and how important that early education is for 3 and 4 year olds in our state, and the trajectory of starting kindergarten early. I know that there is work across departments in this regard, so I might ask Ms. Whetton to add to my comments.
Thanks, Minister. There's currently a children's related committee where we're coming together across departments to look at all issues for children in terms of their wellbeing, education, and the like. The Department of Education, it's something that they've worked with us to a degree on this, but there's a schools mental health fund, and this was a recommendation out of the Royal Commission. You might have heard evidence around this already, but it was $200 million had been provided initially for that mental health fund, and it's so that schools can look at what needs they have for their students and then can select different pieces of work or initiatives to work for wellbeing for their students. And there are also mental health practitioners in schools as well. I'd say as well that there's been a focus on wellbeing for students, that there's a thing called, they call the Framework for Improving Student Outcomes, and that learning outcomes sits alongside student wellbeing. So recognise that wellbeing is, and really particularly think about in the prevention and early intervention space, just how important that is.
So what was that, 200 million?
$200 million was committed. This is going back the 21-22 budget.
And how much of that, or how much emphasis has been put on the importance of Aboriginal children and young people, given the disproportionate impact they have, whether it be impacts of stolen gens, whether it be racism experienced? I mean, we can go on, but I'm preaching to the converted here.
You are. I can't speak to it directly, just that the fund has been developed by the Department of Education. I'm sorry.
Okay. Minister, what do you see your role as in the context to connection to country?
Obviously incredibly important, and that, as I understand it, forms part of that holistic social and emotional wellbeing framework that our ACOs and ACHOs have been delivering in communities. I know that it's something that I'm keen to work with First Nations organisations on what more can be done. And I say that in relation to the aged care portfolio as well as the mental health portfolio, because I know from speaking to a couple of our services, but also some ACHOs, that having Aboriginal dedicated aged care services on country is incredibly important for our elders. So I'm very keen to see what more we can do in that space. And I know that it's incredibly important to properly resource and fund our ACHOs, which is why the social and emotional wellbeing teams being statewide by 2025, I think, is critical in terms of, your point on the importance of country.
And I strategically asked that question, Minister, because my next one is, how many of the traditional owner groups have you met with?
Yes, prior to these portfolios, I was privileged for a short period of time to be the Minister for Environment. So I did take every opportunity I could to go and visit a number of different talks. And I went to a number of forums where all of the traditional owner corps came together, a little bit similar to the forum that we have for health, but just in the context of the Department of Environment.
River Country Partnership Forum.
Yes, that's right. I learnt a lot going out and speaking directly with traditional owners across the state, who are absolutely, they have the knowledge and should have the power to be able to continue to care for country.
And I think as well, access to country is really important. We heard through Land Injustice about the very limited ability for mob to be able to have access to their own country, freehold, or even just the significant barriers that they face. And it does link to mental health and well-being and so forth as well. So I just would continue to encourage you to meet with the traditional owner groups, particularly as you're going to play an active role, as your statement says, around treaty and treaty process and things like that. And it's not to take away from VACCHO and the ACCOs that are doing really important work in the service delivery component of this, or policy advocacy, but we still have access and barriers of access to country, and that's how we heal our people. So the more barriers we can remove around that, and the more funding that goes to language revitalisation or reclamation, will also ultimately also help our people be able to heal, and hopefully we can not have so many of our people having mental health challenges and so forth as well. But as you said, we don't uncouple the systems; they're all one system, and I think it's just really important that I encourage you to keep meeting with those traditional owner groups around how important that is.
Thank you, Commissioner Lovett. I will absolutely do that.
Just to add to what Commissioner Lovett has just said, that he and I both went out to a rehab facility in St Kilda.
Naguala, was it? Yeah.
And one of the things that the men said was, we crave getting out from suburbs, because when you talk about country being important and healing, there's an example where it would really help a lot. With the locating these facilities, but what we were talking about was actually, just having, as part of the program, the ability to get out for a day or 2 days. So, it comes down to those really practical ground level applications.
And having the resources to
and having the resources, of course.
It's important things. Thank you.
Thank you, Commissioners. Chair, as I understand it, we would be adjourning until 10 a.m. on Thursday, the 20th of July. June. I was hoping for a longer break there, but fine. Thursday.
Session, and sorry, I wasn't on. Thank you, Council, and thank you for clarifying that date. And thank you very much for your appearances today. Good discussion, but a very hard space for everybody involved. So thank you. And we do adjourn until Thursday at 10 a.m. Thank you.